Good morning, everyone. Welcome to workshop 2 of the Promoting the Science and Practice of Health Behavior Maintenance series. We're going to give people a few minutes to join the Zoom before we begin.
Good morning, everyone, and welcome to our behavior maintenance workshop on measurement. My name is Sydney O'Connor, and I'm with the NIH Office of Behavioral and Social Sciences Research. Before we begin today's workshop, I wanted to share a few housekeeping notes for attendees and presenters. First, attendees are muted and will not be able to turn on their videos. Live captions can be turned on by clicking the More option at the bottom of your screen and then clicking Captions. The webinar today is being recorded for internal use only. And although the recording will not be distributed to attendees, presenter slides will be shared with attendees after the workshop in cases where we have presenter permission. Due to a very full schedule today, we will not be reading detailed presenter biographies prior to each presentation. However, you can visit our event website to access speaker photos and bios at any time, and the website is listed here on the screen. A couple of quick reminders for our presenters today. Presenters are asked to turn on their videos when they're presenting or participating in a moderated discussion. Additionally, presenters have been asked to share their own slides as a reminder. And to stay on schedule, presenters will receive a quick verbal warning when they're approaching the end of their allotted time. Attendees and panelists may submit questions at any time during the workshop. To do so, just select the Q&A function located at the bottom of your Zoom screen. Questions will be monitored by the moderator and the workshop co-chairs and answered by the panelists or presenters. Now I'd like to hand it over to Dr. Deborah Young-Hyman, who will officially welcome everyone to the workshop.
Good morning. I'm Deborah Young-Hyman from the Office of Behavioral and Social Sciences at the NIH. On behalf of the Planning Committee, I welcome you to the second workshop examining the science of behavior maintenance, part of a series sponsored by the Office of Behavioral and Social Sciences Research and co-led by the NIH-wide Adherence Network. The first workshop occurred in March of this year and focused on conceptualizing the processes of behavior maintenance. Today, our workshop will focus on measurement, monitoring, and innovative tools to do so. The third on Friday will showcase successful approaches to achieving behavior maintenance across behaviors, diseases, and settings, and discuss future directions for behavior maintenance interventions, including real-world considerations. A fourth and final workshop will occur early in 2024 and examine best practices for application in clinical settings. Next slide, please. First, I'd like to introduce our planning committee. Our co-chairs, Dr. Ann Peters and Dr. Alex Rothman. Ann is a professor of clinical medicine, Division of Endocrinology, Keck School of Medicine of the University of Southern California. Ann brings the lens of achieving behavior maintenance through application of best practices in clinical settings. Alex, a professor of psychology, Department of Psychology, University of Minnesota, is a theoretical researcher who is focused on the drivers, mechanisms of action, and processes of behavior maintenance. We are very fortunate to have these two thought leaders apply their unique lenses to the issues impacting healthy behavior maintenance. I also want to thank the NIH co-leads, Mike Stirratt from the National Institute of Mental Health, who co-leads the NIH-wide Adherence Network, Maureen Monahan Center of the National Institutes of Digestive and Kidney Diseases, and Sydney, who you just met, O'Connor, a staff in the Office of Behavioral and Social Science Researchers. They have worked tirelessly to implement these workshops. As Cindy mentioned, biographic and contact information is available for the co-chairs, meeting planning committee, and speakers on the workshop website. Mike Stirratt will now give you an oversight of the rationale for the series of meetings and a high-level summary of key concepts emerging from our last workshop on conceptualization. To you, Mike.
Thank you so much, Dr. Young-Hyman. Welcome, everyone. We're so glad that you're here. I am Mike Stirratt. I'm a co-chair for the NIH Adherence Network, which is an internal NIH interest group that focuses on adherence research. And we're delighted to sponsor this meeting series and work together with the NIH OBSSR and with all of you to meet the challenge of behavioral maintenance. One working definition of behavioral maintenance is sustaining a newly established health behavior by consistently performing it over time and across contexts. Now, any one of us who's tried to adopt a new health behavior knows the challenge. We might start to adopt a new health behavior, like an exercise routine or taking a daily medication, or my current personal effort, which is to stop cracking my knuckles. But it's a challenge to sustain those behaviors over time and to unlearn old habits. In research, one way that we see this is in our data on health behavior interventions. Many health interventions will show some initial success in helping individuals change behavior, but that change is often not sustained, and we see decayed impact from our interventions over time. How could we better help people to not only adopt new health behaviors, but also to solidify and maintain them over time? Is the science of behavior change the same as the science of behavioral maintenance? These kinds of questions and challenges invite us to think further about the conceptualization, measurement, intervention, and practice of health behaviors maintenance. And this is exactly what our meeting series is trying to explore. Next slide. So as Dr. Young-Hyman mentioned, this is a part of an ongoing workshop series. And as a multifaceted concept, we think that it's important to address behavioral maintenance with a multifaceted set of workshops. Today is the second meeting in our series, and the first was actually a working meeting held in June of this year on the conceptualization of behavioral maintenance. And I'll mention a little bit more about that meeting in a moment. Today we'll take up considerations about the measurement of behavioral maintenance. And many of you are subscribed to our next meeting, which is in 2 days on Friday, regarding interventions to promote behavioral maintenance. The series will culminate in a session on the implementation of behavioral maintenance in real-world practice and healthcare settings. And that will be in the spring of 2024. And we have this image here of our overlapping circles for these meetings, and the image is actually purposive because we think as we explore each one of these facets of behavioral maintenance, it'll help to inform our understanding of the others. Next slide. So we did have our initial meeting this last spring on the conceptualization of behavioral maintenance. And although there are too many themes from that to summarize very briefly, we'll just cover a few. And the first is that the meeting highlighted how maintaining behavior change is a dynamic process. It's one with many fluctuations, and these do not always fit neatly into discrete phases or a linear path. Second, it's an active process that can loop over time, experience, and development. The image of a corkscrew or funnel, or even a spring, came to be top of mind for our meeting participants, as people may circle into or out of the practice of behavioral maintenance. What helps them circle in or out? Well, a complex set of influential factors. These factors are at the individual level, as well as social, built, and policy environments. And many behavior change processes are closely rated with behavioral change mechanisms. Finally, our meeting highlighted how concepts of behavioral maintenance can further benefit from greater use of non-stigmatizing language in the future. And we want to try to avoid words like relapse or failure where we can. We're currently working on a further meeting distillation, and we'll make that more broadly available as our meeting series goes forward. So please stay tuned for that. Now let me pass back to Dr. Young-Hyman for an overview of our agenda for today. Thanks.
Thank you so much. Would you prefer I called you Dr. Sterrett or Mike?
Mike is fine too. Thank you
so much for that overview. That was very concise and spot on. This slide has this morning's agenda, which will continue to 1:25, and then we'll have a break. After Dr. Jane Simoni gives her opening remarks, Alex Rothman will moderate the session, Measurement of Behavior Maintenance and Considerations, Establishing Criteria for Success, Measurement as a Precursor to Intervention. Next slide. And this is this afternoon's session, moving from definitions of criteria for maintenance to application, innovative tools and methodologies to monitor behavior in the context of daily life, moderated by Dr. Andrea Mendoza Vascones. Next slide. This afternoon's discussion will end at 4:30. We hope you can join us for the full workshop of integrated presentations. Be reminded that comments and questions can be entered into the Q&A at any time. Comments and questions may or may not be addressed during the moderated discussions at the end of each session because of time, but please be aware that they will be aggregated and help us capture the scientific questions and suggestions sent in by attendees. It is now my pleasure to introduce you all to the new director of the Office of Behavioral and Social Science Research in the Office of the Director of the NIH, Dr. Jane Simoni, who will give opening remarks for today's convening. Dr. Simoni joined us July 30th this year. Her accomplishments are too numerous to share at this time. I encourage you to see her welcome from Dr. Larry Tabak, Acting Director of the NIH. The web link is listed on the slide. We're fortunate to have her join the NIH community and look forward to hearing her perspective as she has worked on the issue of behavioral maintenance for decades. Please, Jane, your remarks.
Thank you, Dr. Young-Hyman. I am thrilled to be here today, and thank you very much for the invitation. I want to just start out with a quick thank you, and an acknowledgement of the long-standing collaboration between our office, the Office of Behavioral and Social Sciences Research, and the NIH Adherence Network. And I know it's long-standing. I believe even as a young investigator, I attended one of the early meetings that we had at NIH. I want to thank all the NIH organizers, including many from our office, as well as NIMH and other offices across the NIH. And also special shout out to our two external co-chairs, Drs. Alex Rothman and Ann Peters, especially appreciate having some support from outside the NIH. So this is very exciting to me because I have been a long-term researcher as a clinical psychologist, very much interested in behavior change and how to maintain that behavior change. And though I've worked in the arena of HIV, I know the issues are really cross-cutting across diseases, and I see that here at the NIH. This area is as important as it is challenging. And I remember talking with my colleagues at some of the conferences, we would say, you know, what part of your portfolio is adherence or behavior change research? And they would say, not all of it, because I don't think I could be in a career that was as challenging or as frustrating as trying to change human behavior and do it full time. And others of us would say, I know even working with NIH or HIV medication adherence, that it was very difficult work, and we were all waiting when they would just have a patch and people could put on a patch and they wouldn't have to take a pill every day. So we just know it was very difficult to do that work. And I know when I was in the midst of this research once, I was on a bus and I saw even the bus driver had a little sign that put up in front and said, we know it's hard to change behavior. Just look at yourself and what you're doing. So we know we couldn't change our own behaviors. As Mike humorously pointed out, it's very difficult to do it with folks that we're working with. So I'm very excited today to be listening and hearing what you have. I want to know that OBSSR is a very large priority to understand the mechanisms for behavior change and interventions and implementation of interventions to change and maintain healthful behaviors. So I'm very interested in what I will learn from this workshop today, and I hope to be able to attend some of it on Friday as well, because I think it will give us some directions about how our office can be supportive of research in this area. So I hope folks that are listening today, that our researchers will think about how they can translate what they're hearing today into research projects to help us implement this knowledge and contribute to promote well-being among everyone. So thank you very much, and I'm very excited to hear what's on the agenda.
Thank you so much, Jane. I'm now going to transition the podium to Dr. Alex Rothman, who will moderate our next session. This slide shows you the topic and the speakers. To Alex.
Hello, everybody. I want to thank my co-chairs, Anne and Deborah and Sydney and Mike and Maureen and OBSSR and NIH for helping us put this together. And I want to thank all of you for joining us today. This is, I think, it'll be an exciting discussion. What I'd like to do first this morning is just to sort of set up panel one and give you a little bit of feel for what we're hoping to sort of focus on this morning. And then I will turn it over to the people. We've got just an outstanding collection of experts who will be talking and sharing their expertise with you. So first, let's just sort of set this up. And in some sense, the presenters before me have sort of emphasized this, but let me just sort of reset it again, which is that all of us are interested in different ways in maintenance of behavior change often. And partly we're interested in this is because there are many key health outcomes really depend on people maintaining patterns of behavior, sort of maybe they're not only just quitting smoking, but sustaining that quit, starting to take medication along following some sort of treatment guideline, and then sustaining or maintaining that pattern of behavior over time. And in some cases, it might be maintaining an outcome that is the sort of proximal consequence of a set of behaviors. And the primary example maybe today, and what we'll hear about is sort of people who have successfully made changes to lose weight and are working to try to maintain that weight that is lost. And because of our interest in these issues, there's a large body of research, many probably done by the people on this Zoom webinar and others, that is focused on predicting maintenance, trying to understand who is it that's sort of able to be more successful here, able to maintain a new pattern of behavior, and what are the conditions that people find themselves in that might facilitate or inhibit their ability to maintain behavior. And then complement to that, there's part of the research community that's much more intervention focused and sort of focusing on developing and testing interventions that promote maintenance, sort of figuring out what are the strategies we can use that to enable people to maintain often a newly adopted pattern of behavior. And while this is a focus of much of the work that's been done, I'd like to suggest that, despite our collective interest in these questions of predicting or promoting maintenance, discussions of how we conceptualize and operationalize maintenance have been somewhat more limited. And I think and in particular, the conversation about, well, actually, what is maintenance look like? What are the defining characteristics of maintenance? What those look like across different behavioral domains is also something that I don't think has been given a large attention. And then something that we're going to really, I think I'm excited about the opportunity to have that conversation today. And so when we think about maintenance, I'd like to just sort of begin to sort of tee up a couple of things for you to keep in mind. So maintenance can really take many forms. So sometimes it's to involve consistently not doing a very particular behavior, maybe not smoking. It could in other cases be consistently doing a particular behavior, taking a particular pill at a particular time of day, maybe every morning. Other times maintenance might involve consistently doing a behavior that is more than some set criterion or threshold, right? So I need to be more physically active above a certain threshold over a certain number of days over a week. Or it might be in other cases consistently doing less than a particular threshold or behavioral outcome. Sort of if you're monitoring, for example, your caloric intake, and then you're wanting to keep your behavior at a level below that threshold. So in these different forms, and then maybe in these different forms that maintenance can follow, we might find ourselves asking a variety of different questions. Okay, first of all, is there a specified period of time that a behavior must be performed or an outcome achieved in order to be characterized as maintenance? So if you've been quit smoking for 2 days, or if you've been physically active for 3 weeks, is that enough to sort of think about that person is now transitioning to a phase that we might want to characterize maintenance? What is this? Is there a time frame we want to think about? And is that time frame similar or different across behaviors, across contexts? Similarly, is there a threshold that we're interested in that's key here, that specifies a behavior or an outcome that somebody either needs to meet exactly, they need to exceed, or they need to avoid reaching in order to achieve maintenance? And then finally, are there other indicators? Are there psychosocial, physiological indicators that need to be considered as we conceptualize and operationalize maintenance? And and then I'll just sort of make more broadly, do these conceptualizations look different across different contexts, right? So is our conceptualization of maintenance consistent across context, settings, and over time? And so what we will be, and then, sorry, one more point I just want to make is that as we think both about how we conceptualize maintenance and how we're thinking about it and how we want to operationalize maintenance, there is also the flip side of that, which is then how do we conceptualize and operationalize deviations from maintenance, right? What patterns of outcomes or behaviors might be taken as a sign of concern? When is it that we're monitoring people over time when we might be able to say, this person is beginning to deviate from maintenance? So is it the case that, when they drop from 150 minutes of moderate vigorous physical activity down to 140, is that the moment in which we should be concerned? Is it a drop from 150 to 130? And to take physical activity as an example, in some cases, we have clear ideas of what these deviations might look like, but maybe in other cases we don't. And that's obviously something that we want to be thinking about in order to be able to prepare to sort of think about how do we design or develop and deliver interventions that might assist people as they might potentially be struggling to be successful around behavioral maintenance. So with that having been said, what I'd like to do is turn it over to our distinguished group of speakers, Megan Piper, Genevieve Dunton, Adam Leventhal, Stephanie Goldstein and Rita Wing, and Jessica Haberer. They are, as you can see on the slide, they will each be talking about a particular domain for which they have just tremendous expertise. And so they'll be talking to us, for example, in a moment, I'm going to hand the podium over to Megan. So they'll be talking about these issues, about how behavior maintenance is conceptualized and operationalized within each of these behavioral domains. And I think we'll see sort of interesting both consistencies and perhaps inconsistencies, and sort of as we think about what are the strengths and challenges of thinking about behavior maintenance in each of these domains. We will we'll hear from each of our speakers. They will sort of hand off the podium from one to the next. As others have said previously, if you'd like sort of more information about the speakers, including their contact information and relevant publications, it can be found on the workshop website. But once Jessica Haberer is concluded, I will bring all of our panelists back together for a moderated discussion where we'll be able to talk about some of the themes that have emerged out of these presentations. And I also welcome you to submit questions as well that have come to your mind. So to take note of those, either note them as we're going along in the Q&A or note them at the end when we wrap up. And I look forward to seeing all of the presentations. So with that being said, I will pass the baton to Megan.
All right, thank you. Let's see if I can do the sharing properly here. Does that look proper? Wonderful, thank you. Well, I appreciate this opportunity to have a chance to talk about defining and measuring maintenance with respect to tobacco control. Let's see. So just to orient those who may be less immersed in this activity, smoking commercial combusted cigarettes is the leading preventable cause of death and disease in the United States. And what's important about this behavior change is that moderation doesn't necessarily equate to improved health, because smoking even one cigarette per day increases the risk of cardiovascular disease and other negative health events. So really the goal for tobacco control research and tobacco treatment research is to get people down to smoking 0 combusted cigarettes. And we've had tremendous success in terms of public health achievements. We're down to 11.5% of the adults in the United States are smoking, but that still translates to more than 28 million adults in the United States. And the bigger problem is that that burden is not borne equally across population groups. The smoking rates are unfortunately higher, considerably higher in specific groups, such as those with lower education, those with serious psychological distress or mental illness issues, those from certain minoritized racial groups, and those who are members of the LGBTQ+ community. So it really does equate, health equity and the need to help people quit smoking as truly important issues of public health and social justice. So one of the big organizations that promotes research in this area is the Society for Research in Nicotine and Tobacco. This is the preeminent international organization that supports research. And they have convened, in 2003, they convened 2 groups of experts to help identify the best ways to operationalize abstinence, both from self-report and also from biochemical confirmation, because of course, abstinence from combusted tobacco is the #1 public health goal. These reviews were updated in 2019 and 2020, and that's what I'd like to share with you today. So there are a lot of different features when we think about abstinence, and there's a lot of different components that we have to discuss and talk about as we try to figure out when is somebody really abstinent, when has a treatment been shown to be successful, when have people gotten into that maintenance phase, as was discussed, where they're not actually trying to quit anymore, but they've established themselves as someone who no longer uses combusted cigarettes. And one of the first issues is which products get included in the definition. SRNT is recommending that you use, and I'll talk about the definitions in a second, but the definition A is used for all smoking cessation trials, but we want to make sure we're collecting enough data on product use so that we can do sensitivity analyses using these 2 other definitions. For example, definition A is abstinence from all combusted tobacco products. Again, that creates the biggest health risk. And so you want to make sure, nobody is smoking anything. So that would be cigarettes, cigarillos, little cigars, regular cigars, but it would allow, quote unquote, the use of non-combusted products, smokeless, snus, as well as alternative products like electronic cigarettes, heated but not burned products, things like that. So that's one that we want, the society wants everybody to be able to use as an abstinence definition. But then these other more flexible ones would allow, insist on abstinence from combusted products and smokeless products, but allow alternate product use. And then the third definition is abstinence from all tobacco and nicotine products that are non-medicinal. So that would include all the combusted, all the smokeless, and all the alternative products. Then one of the next questions is, how do you measure? Where is it maintenance? What is the period that what's the type of abstinence that we're going to be looking at? So true maintenance, right, would be this top one, this continuous abstinence from the quit day all the way through to the day that you're assessed you have not smoked at all. That would truly represent maintenance, complete behavior change. The definition of prolonged abstinence allows a little bit more reality sometimes, where smoking is permitted a bit during the grace period. It's not uncommon for people who are trying to quit smoking to set a quit date and try, but take a little time to actually be able to maintain that abstinence pattern. And so then you would look at their smoking following that grace period. There's another definition that allows some slips where smoking is permitted during the grace period, and then there's a couple slips allowed during that subsequent non-smoking period. However, I will say that in smoking research, people who have an initial slip or two following an establishment of abstinence, so not during the grace period, but once they've established abstinence, having 1 or 2 cigarettes, almost 90% of people that do that end up back in a regular smoking pattern. So really for maintenance, we're looking at a 0 use definition for people being able to maintain a non-smoking pattern. And then the most common, I think, typically that we see in research is point prevalence. So, and the example on the bottom of the graphic is repeated point prevalence. So I haven't smoked at all in the last X number of days. And when you think about how we actually measure this, right? So SRNT recommends looking at point prevalence abstinence and prolonged abstinence as those being your 2 primary assessment measures. Point prevalence abstinence is the way we typically assess that is in the last 7 or 30 days. Have you smoked a cigarette, even a puff? And again, this would be specific if your definition, you're using that key definition of abstinence from combusted products or cigarettes only, but allowing other product use. You can see that repeated point prevalence abstinence, it's the same question, you just do it repeatedly over time. Continuous abstinence is just, have you smoked a cigarette, even a single puff, since the target quit day? And then prolonged abstinence allows that grace period. Since, a week or two after your quit date, have you smoked a cigarette, even a puff? And then the prolonged abstinence that allows a little bit of slip, which is probably the most concerning in terms of concern about escalating of those slips into relapses, would be since the end of that grace period, have you smoked more than 5 cigarettes? Another way to ask that is, how many cigarettes have you smoked since the end of that grace period? Another key feature that we think about is duration of abstinence. And before we talk about the duration, we have to talk about where you start, right? So there are 2 different types of treatment trials in tobacco research, typically. Aid to cessation, where people are ready to quit smoking and they're going to set a target quit day. That's part of the protocol. And then all of the abstinence assessments are keyed on that target quit day. And also in these aid to cessation trials, the treatment duration is, it's targeted based on that target quit day, and the treatment end is specified. There are also cessation induction trials where people are not actually motivated to quit smoking, or they may be or may not be, but they enter into the study. So this could be an example of inpatient folks who get physician advice and a smoking cessation consult, and they may or may not be willing to quit, but then we assess whether or not they've been able to quit at a certain time down the line. And like I said, those don't have a specified target quit day, and they may not even have a clear treatment end. Everybody gets a referral to the quit line. You never know when the person calls the quit line, if they get a hold of it, that sort of thing. But what we do talk about then is, regardless of whether you're starting based on a target quit day set by the protocol in an aid to cessation trial, or you are doing it based on when they were enrolled or randomized in the trial as part of a cessation induction trial, from that point, SRNT is recommending that minimum you're collecting data through the end of treatment. So we want to be able to know during treatment, what's the effect. It's a little complicated with cessation induction trials, but that's one of the primary drivers, is during cessation, is it actually able to help you quit? Then also we want to know about longer term, at least 3 months after the end of treatment. That gives us an idea of whether these treatment effects persist over time. And then the gold standard is 6 months post the tobacco quit day, or post-treatment initiation. This is what's typically used in Cochrane. This is what we used when we developed the Public Health Service Guideline. It's sort of the long-term quitting, really demonstrating that somebody has actually been able to maintain this behavior over an extended period of time. One of the tricky pieces when you're doing this research, though, and you're setting your outcome, and this is something I don't think we talk enough about in the smoking cessation world, it's very rare that we have a condition where we test whether the treatment works 3 months after the person is done using the treatment, right? We don't use that with hypertension. We don't use that with hyperlipidemia treatments. And so that question of what's really driving any sort of lapse or relapse that might happen from the end of treatment through that 6 month, most treatments tend to be 3 months long, and then you have a 3-month non-treatment effect before you hit that 6-month gold standard. And so that's definitely something that I don't think talk enough about in terms of whether or not we're measuring what's clinically appropriate to determine whether a treatment's successful, or whether the treatment has given the person what they need to be able to maintain their behavior change once the treatment's been discontinued. In addition to self-report, we also created new guidelines or new recommendations regarding biochemical verification of abstinence. And why is biochemical abstinence or biochemical verification important? It really does enhance the rigor and validity of any sort of self-reported smoking abstinence. And this has become more of an issue over time. It used to be that in certain groups, we really were concerned, it tended to just be people who were pregnant because of the stigma of smoking during pregnancy. But as social norms have changed, and an increasing number of person factors are now related actually to people misrepresenting or misreporting their smoking behavior and not having it being able to be biochemically confirmed. For example, in a clinical trial that we conducted in 2018, we found that we were only able to biochemically verify a third of the self-reported abstinence rate. So really in our biochemically verified abstinence, only 6% in a treatment condition were abstinent versus the self-report in which 18% were abstinent. But there's important limitations when it comes to biochemical verification, right? The challenge of confirming long-term abstinence based on the ability of the biomarker, the half-lives and the chemistry involved in the biomarkers being able to indicate when the last time somebody used a tobacco product was. There's implementation challenges. You know, sometimes when people go back to smoking, they drop out of studies, they don't want to participate anymore for lots of different reasons. Getting people to come in to do the testing is a challenge. There's extra costs for sure in terms of some of these biomarkers are very expensive, some are much more economical. And then, of course, there's a need to have a clear analysis plan for how you deal with missing verification data if you have self-report but no verification. There are lots of different options, and I'm not going to go into them in detail here, but just know that we have a cotinine option. Cotinine is a metabolite of nicotine. You can get that through plasma, saliva, and urine. There's exhaled carbon monoxide. There's some minor tobacco alkaloids and NNL, which is a carcinogen that's specific to cured tobacco. And what's important about these is that they have, we were able to establish specific cut points, which is very helpful for investigators. But here you can also see the average half-lives differ. So for exhaled carbon monoxide, it has a half-life of 2 to 8 hours. So you're not going to be able to detect somebody who started, you know, if you're asking, have you smoked at all, even a puff from your target quit date to 6 months post-quit, that biochemical verification is only really going to cover the last 24 hours. And so thinking thoughtfully about how you're going to select which biomarker you might use, we were actually able to provide a table to help people sort through. So if you wanted to identify abstinence from cigarettes and other combusted products, you could use any of the biomarkers, but you would have to, if you were looking at e-cigarettes, you obviously can't use exhaled carbon monoxide. You could use any of the other products. But if you had somebody and you were looking to see whether they were quitting smoking and you were having a nicotine patch and you were doing an end of treatment abstinence assessment, you have to recognize that if you're getting cotinine, some of the nicotine detected in that test might be from the patch itself, not necessarily just from the combusted product. So really the recommendations were, if you're looking for recent smoking abstinence, sort of a point prevalence abstinence estimate, cotinine or carbon monoxide are the best options. And if you really need to try to tap a biomarker for long-term quitting, NNL, which is a more expensive biomarker, but it's specific to cured tobacco, which makes it a very nice, precise measure of that, would be the option. So overall, the recommendations that SRNT experts put forth is, you know, if researchers do opt to use biochemical verification, you really, again, have to make sure that you're sharing all of the important methodologic details, sample collection and storage, analytic methodology, type of CO monitor used, all of those things. And you need to decide which biomarkers and biofluids are the most appropriate for the study. Are people going to come in? If you need a plasma sample, is this something where you could send out saliva kits and how that would work? And you also have to make real sure that your biomarkers are appropriate based on all the different products that are going to be used in a study. And I didn't mention this earlier, but more and more we are seeing co-use of tobacco and cannabis, perhaps not simultaneous use, but people using both products. And so when we do carbon monoxide testing, we also have to make sure we're looking at other combusted products, including cannabis. So that's sort of how we assess maintenance, looking at the long term. And so what are some of the key challenges is trying to figure out which outcomes are clinically significant. As I said, does it matter if you were able to stay abstinent from smoking your entire 3 months on the medication, but once the medication was gone, you relapsed? Is that a sign that the medication didn't work? Is that a sign that, you know, or is that a sign that you might be someone who needs sustained medication in order to be able to sustain your maintenance off of cigarettes? We always have difficulty with follow-up completion, and it's really hard when you have that, especially if it differs by person factors. So if we are less likely to get follow-up data from certain groups, then we have a less efficient estimate. What we tend to assume in smoking research is that if we don't have follow-up data, that person is most likely to be smoking. There have been some great methodologic papers done by Don Hedeker and others looking at the veracity of this. And a lot of researchers tend to use sensitivity analyses, but it's definitely something that we struggle with. There's always the challenges of determining which products should be included in the definition. That's why the SRNT group recommended the sensitivity analyses. You know, is it okay if somebody's not smoking, but they're still using e-cigarettes? That's a harm reduction approach, but is that considered a true, is that the goal of the research study? If it is, that's great. But if not, if they have to be off all products, then how does that play into whether someone's actually maintaining an abstinence from tobacco? And then obviously the difficulties with biochemical verification in terms of feasibility, cost, long-term abstinence, and the differentiating between all the different products that somebody could be using. But there are some opportunities. I think one of the big things that we're thinking about more is using technology to try to get better assessments, using text messaging and apps so that we have a better sense of what people are doing over time. The other thing that technology is allowing us to do too is to look more at some of those opportunities to identify when is someone starting to slip.
Warning.
Thank you. When is someone starting to slip? Just in time adaptive interventions that might be triggered based on where somebody's located or current cravings. Other factors are something that we as a field are trying to look into doing to helping someone before they start to have that initial lapse or a relapse where they have sustained smoking over 7 days. And that's something that technology can help us do. And then technology also is allowing some remote sensors. People can now be mailed CO monitors. They cost about $60, and they can take their own CO at home and help us be able to verify the self-report of their smoking status at the time. So with that, I will happily conclude and thank folks for their attention. And I'm going to stop sharing so that the next speaker can go. Thank you.
Okay, great. Well, that was a wonderful overview of maintenance measures in the smoking field. And hello, everybody. I'm Genevieve Dunton, and I am excited to be here today. And my plan is to give you an overview of the state of the field in terms of our progress in coming to consensus on how to operationalize and measure physical activity maintenance. So I'm going to start by talking about why we care about maintaining physical activity over the long term. And the primary reason is that maintaining physical activity is necessary in order to achieve the health benefits and the disease prevention benefits that we have seen. So in the United States physical activity guidelines, it's recommended that adults are maintain activity and are active most days of the week, up to 150 minutes of moderate to vigorous activity. And this isn't something that people can do over just a few weeks and expect long-term health benefits, right? This is something that physical activity needs to be sustained over months and years in order to see some of these long-term cardiovascular, cancer, diabetes prevention benefits. But the problem is that at least some of the emerging data that we have suggested that lapses or periods of disengagement with physical activity are quite frequent. And in a study that David Conroy published, amongst women that were maintaining activity, about 60% had a period of disengagement or a lapse that was over 2 weeks long across a 6-month period. So this is a quite common occurrence. And we need to be aware of these lapses because they can have some negative physical and mental health consequences on their own. So there's research suggesting that even if physical activity levels decrease for 2 weeks, many of the cardiovascular and cardiorespiratory benefits that have been achieved will start to diminish. So people can start to experience the effects of detraining with disengagement over periods 2 weeks or more. And then one thing we're concerned about is that these periods of disengagement can lead to vulnerability to permanent failure to re-engage in activity. And so back in the David Conrad study with women, those who did experience a period of disengagement for 2 weeks or more, about 39% of them then did not re-engage. So they just kind of stayed in a period, in a phase of permanent disengagement. So this is something that we've already heard a bit today, and that when we look at specifically in the area of physical activity, that maintaining activity is difficult, and especially in the intervention realm. And so many physical activity interventions do target the initiation or adoption of physical activity. And then those that do collect post-intervention follow-up data, we often see this triangle type of shape where we see that levels, initial gains in physical activity start to diminish. And often in the post-intervention follow-up periods, the intervention group often goes back to a level of activity that's quite similar to a control group. So the challenge that we face in the field of physical activity, which is quite different than what we heard about in maintenance, is that there's quite a lot of ambiguity and potential confusion about what physical activity maintenance means. So we don't have a common standard definition. And for that reason, it is difficult for us to conduct surveillance of maintenance. So at any given time, we have some good potential, I wouldn't even call, they're point prevalences of physical activity engagements. We often ask over the past 7 days, how active have you been? But we have no idea from those type of surveillance measures how long someone has been engaging in activity. And then because of that, the field is in a very early stages of being able to investigate risk factors for failing to maintain or disengaging in activity. And then we run into a number of challenges because of these lack of definitions for our ability to compare the results of interventions that are seeking to promote maintenance. And so thinking about the field of physical activity, we can think about defining something conceptually, which is what the construct means. So what does maintenance mean conceptually? And that's what was the focus of discussion for the March maintenance workshops about 6 months ago that were part of this OBSSR series. And then today we're thinking a little bit more about operationally then. The operational definition is how do we measure it? And in the field of physical activity, we're at a really interesting point because there's essentially two perspectives in the field. One is that to define physical activity maintenance conceptually, that means something that we are thinking about in terms of outwardly observable behaviors. So there's a behavioral conceptual definition, which suggests that this is sustained behavioral engagement that we can be outwardly observed. So something that we can ask people about in terms of the behavior that they're engaging in. We can measure it through devices or other monitors. And that's in contrast to a more emerging definition of behavior maintenance and physical activity, which suggests that we need to take into account in the definition some of the psychosocial processes that may mark a shift between an initiation and maintenance stage. And the reason is that in physical activity, someone can be engaging in a level of outwardly observable behavior, and that is pretty indistinguishable in terms of what's going on underneath the surface. And so that's why it's helpful to think about this in terms of the kind of classic iceberg metaphor, that when we may have operational definitions that we can observe the behaviors, but we don't know what's going on underneath the surface. And the suggestion that we need to take into account these shifting psychological and psychosocial processes. So in some cases, this may be a shift from more deliberative decision-making to more automatic decision-making, that should be a marker of physical activity maintenance. When you look at the field, and we recently completed a review paper in this area, and we look at what type of measures have been used to operationalize physical activity maintenance, they tend to fall into 3 different indicators. And Alex introduced some of these earlier before the beginning of this session. And one is we need to think about the threshold. Because physical activity is a continuous behavior, in contrast to perhaps some of the smoking or substance use or eating behaviors, which may have more kind of discrete episodes, we need to think about what threshold is important. So what threshold must someone cross in order to be considered maintenance? And a logical place is to look at the physical activity guidelines, a recommendation. So 150 minutes of MVPA per week. However, that may not be a useful threshold for everybody, especially individuals who feel like maintaining a behavior, they may be able to maintain a behavior maybe slightly below that threshold. So maybe they can maintain 100 minutes of physical activity per week, and they can maintain that, and that's feasible for them over months and years. So there's been some calls for thinking about idiographic or person-specific thresholds that we can use to define what maintaining behavior means. And then another indicator that is critical to the definition of how to measure physical activity is how long, right? Or the period of observation. So this is the length of time. It could be, what we've seen in the literature is that it could be 3, 6, and in some cases 24 months people have used as a definition for how long behavior needs to be above the threshold in order to be considered maintenance. So in the same way, how do we define disengagement or maintenance failure? And in some cases that in the literature been defined as a single session, maybe 7 days of not engaging in activity, or in some cases up to 3 weeks. And then a third indicator that's important when we think about the definition is the consistency or stability, or in some cases, what type of allowance how much time under the threshold do we allow for somebody to still be considered maintenance? So the idea that somebody needs to do a certain level of behavior every day may not be realistic for physical activity, that there's going to be days that they don't, and that's just going to be built into their routine. But how many days are we going to allow under the threshold in order to still consider that maintenance? So these are some of the challenges that you can see. So because of these challenges, we do have quite a bit of inconsistency in the field. I mentioned one, physical activity is a continuous phenomena. And so this is something Alex mentioned earlier. If someone does 5 minutes less of physical activity, maybe they are doing on a certain day, then is that a lapse or is that disengagement? And then in contrast to behaviors such as smoking or substance use, physical activity maintenance involves doing something, right? An act of commission instead of omitting something. So then we need to think about how long someone needs to be doing something in order to be considered successful maintenance, right? Whereas somebody who has a quit date and they may be successful 24 hours later at abstaining, that may be success, but for physical activity, that's just one day of doing the activity. That's hardly a threshold or a criteria probably for considering maintenance. And on the other hand, disengaging with physical activity involves an error of omission or not doing something instead of commission. So for that reason, the concept of total abstinence may not be realistic or useful. The idea that someone needs to never not engage in physical activity is probably completely unrealistic. So at what point, how many points of disengagement are allowable? But certainly the idea of the opposite of total abstinence or total engagement is probably not a useful part of a definition. So because of this inconsistencies, we recently, Alex and others, and I put forth a paper where we proposed a beginning of a conceptual model that suggested points of inflection. And these are each of these stars along here, this model. And each of these points of inflection need to have operational definitions of maintenance defined for them. And so that would be thinking of periods. We need to define the threshold and the period of observation and the consistencies for each of these. And so what level of physical activity should be the target? And I mentioned earlier, these could be nomothetic, meaning general thresholds that we apply to everybody, or these could be idiographic. These could be unique to that person. So it could be their own personal median or just below their personal median or above, and consider that if they can, their maintenance. There's a wide range of periods of observation. So how many days does somebody need to be above the threshold before we consider that maintenance? You can, there's, I mentioned that the literature has a wide range, and there needs to be systematic testing of these different options. And then the same thing for consistency. There could, how many days allowance should be available for them to be under the threshold. So we propose a framework, and we're working on this for the field to start to come together to operationalize maintenance. And this involves comparing the prevalence of physical activity maintenance across the different values of the indicators, and then comparing and looking at the validity and the accuracy of the different values of indicators against different criteria that we might have. These could be behavioral or psychosocial. And then comparing these indicators across different populations and time periods. And so when we think about comparing the prevalence, we're thinking about the number of days that people may be in maintenance, or the duration of the maintenance periods. And so just for an example here, we have some data that we collected over 12 months. And you can see that when we look at these different thresholds, this is the same participant. You can see that when we look at a nomothetic versus idiographic, and we look at the green period, very different prevalence of maintenance days comes out. When we compare different number of days above the threshold, we can see that there are different numbers of maintenance days, and the same thing for allowances for days below the threshold. And we also can compare the validity and accuracy of these different indicators, and there's a wide range of external criteria. So I'm going to just conclude here with a point that what we really need in the field is intensive longitudinal measures, because physical activity is a continuous phenomena. That having point prevalence measures is pretty difficult for us to understand physical activity maintenance. And then one thing we need to consider in the field is incorporating psychosocial processes into the assessment, and that the things that occur under the surface may be as critical as what we see above the surface in defining maintenance. And then we need to really coordinate systematic and prevalence and validation testing of physical activity maintenance across studies. So I will conclude here. Thank you.
Good morning, good afternoon, everyone. Really excited to be here. Let me do my screen share. Okay. You can see everything okay? Someone give me a thumbs up or something. I can't tell, but
It looks great.
okay, thank you. Okay. My name is Adam Leventhal, and I'm faculty at the University of Southern California. And I'm going to be talking about addictive behaviors and behavior maintenance and change processes. So one of the things that's, when I was putting together this slideshow, at first I was thinking a lot about people who are trying to reduce or quit using a substance. And then I thought, well, you know what, we could take a step back, because addiction is a much broader developmental disorder, and there are many forks in the road. And if we're interested in preventing people from escalating and other types of factors, in the maintenance of those targets, we should probably consider a broader span. So what you're looking at is a model, really just a descriptive model of various stages of the addictive process. And what I want to do is go through these various stages and then talk about some of the constructs and measures that we use to define whether and how people have forks in the road to get off this cycle of addiction risk. Right. Oh, yeah. And then, of course, it's important to note that there are risk and protective factors that sometimes are the same and sometimes are different across these various stages. And of course, so it's important to study these if we're trying to target a behavior change process to promote health. So let me talk about susceptibility. This is a construct that I believe was developed by John Pierce, originally to understand smoking in youth. And one of the goals was to see if scientists could predict whether a youth was at risk to start smoking. And of course, this can generalize to other addictive behaviors, and there's evidence suggesting it does. And so it's a social cognitive construct that involves just a few items that ask youth about whether or not they're curious about a substance, if they'd be willing to use a substance, if their friends offered it to them, and if they had a plan or intention to use the substance in the next, let's say the next 6 months or some sort of defined period. And so amongst people who have never used a substance, those who say, who do not respond absolutely no to all those questions are considered non-susceptible. So even something like somewhat disagree in terms of a Likert scale response, those people will be considered susceptible. And so that's an important target. We want to prevent people from even becoming susceptible to using dangerous substances. And so either you're non-susceptible or you're susceptible, and that routes you into initiation, which we can define as ever using a substance, although there are some other definitions, but just thinking very broadly, just taking one puff of a cigarette, for instance. So, and then also I just mentioned expectancies. So that's also a key construct that comes into play often when we're trying to understand susceptibility, is the people's cognitive expectations about if they took a substance, what would be the effects? Would they be reinforcing? So the next step in this chain is so once people try a substance, they can either continue using the substance and escalate, going on a path towards a substance use disorder, or they cannot be, have a persistent pattern, and they can, desist and stop using the substance, or not fall into a harmful pattern of use of the substance. And some of the things that we think about are the inherent abuse liability of the substance. So holding all things equal in terms of the social determinants, the environmental determinants, different drugs will have different inherent abuse liabilities in terms of their neuropharmacological effects. And so because of that, we often think, and we often want to prevent young people from even trying a drug, because there are important factors that are hard to suppress when someone who may be vulnerable uses a drug, finds it very reinforcing. They're much more likely to go on to escalate. But there, of course, are all sorts of other determinants, price, discrimination, availability of the substance in your neighborhood through retailers, illicit markets, and whatnot. But so that gets you to regular use. And so, you can stay in the cycle of regular use for a while, and that's just the continuation of the addiction process. But of course, we're interested in whether people can reduce or stop using a substance, and I'll talk about that in a second. And a lot of times when we think about what takes people who are using a substance to actually make an intentional effort to reduce or stop using a substance, we often think about the stages of change model. And so many of you are familiar with that model, and it has a very nice application to addictive behaviors. And so there are measures of what stage people are in. But there are also brief measures of motivation or intention to change. And one of the ways that we measure that is we can ask whether someone has a serious plan to cut down or quit using a substance in a predefined period or date, right? And so usually if it's within the next 30 days, or within the next 6 months, or within the next year, we can classify that as different levels of preparation towards the stage of making an intentional quit attempt or substance use reduction attempt. So a little more definitions of how do we define what is a bona fide attempt. So there's abstinence, and so we could use self-report. And so we'll rely on whether or not people reported any use of the substance at all in a well-defined period. And Megan did a great job talking about all the advances in the smoking cessation literature. And then, of course, we biochemically verify, just like smoking, we do the same thing for other substances through biomarkers. But something that's a little less common in the smoking literature, but more common in other substances, is reduction as a target. And so sometimes we have some objective quantitative thresholds, such as whether people who have an alcohol use disorder, their target may be not engaging in any binge drinking days, but no drinking at all may not be a target to be considered engaged in the behavior change process. And there are all sorts of other interesting alternative outcomes that are being studied that are quite important, such as improvements in the quality of life, and no substance use disorder related consequences, so the physical effects, mental health effects, social, employment, legal effects. And so, there's an argument to be made that if someone's not having any adverse consequences of using the substance, but they still are using it at some level in a way that's not harmful, then that is a positive outcome. And then, of course, there's remission of the DSM-5 substance use disorder symptoms, which you can obtain through a clinical interview, such as the SCID. So, taking it back here to this model, when we get to this point, the question is what this idea of recovery is something that has been around a long time, and its origins are from the 12-step movement, which is alive and well. So organizations such as Alcoholics Anonymous, Narcotics Anonymous, which is a very widespread way in program in which people stop using a substance and engage in this process of recovery. And so this is, even though it's been around out in the real world, scientists have really not been studying this heavily until the past 5 or 10 years. And so the question is, how do you define what recovery is? And it's very interesting because recovery doesn't just mean I'm not using the substance. Because if you have all sorts of other problems that are happening in your life, but you're not using a substance, that's not considered clinically a good outcome. And so the science of recovery has really, let me skip through this, has really taken shape. And so I refer folks to this, the Recovery Research Collaborative paper in 2019, Addiction Research and Theory, in which there was a working group of experts, and they defined recovery as an individualized, intentional, dynamic, and relational process involving sustained efforts to improve wellness. So there's a number of measures that are continuously in development. And then also there are some really short questions too. And so asking things like, have you had a problem with alcohol or drugs and are no longer do, or do you consider yourself in recovery? So John Kelly does really, really great research on this topic. And the answers to those two questions are not mutually exclusive. And so that's something to be, that's important to consider. So in terms of challenges and future directions, So we really don't have any agreed upon timing thresholds for what constitutes maintenance, right? There are some rules of thumb about 30 days, 90 days, 1 year in terms of differential levels of risk. But, there's not a massive body of evidence to support them that would lead us towards any one definition. Recovery is a dynamic process that's individualized. And the interesting thing about addiction is the actual disorder itself, and one of the criteria for substance use disorder is repeated unsuccessful efforts to cut down or quit using the substance, right? And so from a behavior change perspective, that means the failure to change the behavior. So it's kind of a little tautological sometimes when we think about addiction, but that's what makes it interesting. So the different substances may have different phenotypic expressions. So that means, I was talking earlier about reduction and how that may be more relevant for certain substances versus others. We wonder, where do we put harm reduction in this, right? And so, Megan talked about switching from combustible to non-combustible tobacco products. And there are other types of harm reduction too, such as using a substance in a safer way, such as, getting involved with needle exchange programs for
1 minute
people who use
warning.
drugs. Thank you. And then I think the future directions really include examining the predictive validity of definitions of recovery. And there's some really outstanding work by some in the alcohol literature, and Katie Wickowitz leads some of it, where there is reanalysis of large clinical trials to identify alternate outcomes in clinical trials based on reductions that are not just abstinence, and trying to validate those reduction metrics to predict long-term health outcomes that we care about, right? Of course. And so including quality of life and lack of physical disease and other things. So check out this website if you want. The Mass General Hospital Recovery Research Institute is a great resource, and they're really leading the charge in recovery science. Thank you for your attention.
All right, thanks everyone. Can folks see the screen?
We
Holy
can see the
cows.
screen, but we can't see you, your video.
Oh, yeah, I can do my video. Hello, everyone.
Thank you. Perfect.
So Dr. Wing and I are going to be presenting on weight loss maintenance, and Dr. Wing, I'll let you go ahead and get started. Rena, can you unmute yourself?
Okay, good, great. Good going. Thank you. Someone just unmuted me, which is great. Thank you. So first of all, thanks for inviting us to present. I'm going to share this time with Stephanie Goldstein. I'm going to talk first about the weight loss criteria and maintenance criteria, and then Steph will talk more about the behaviors that go with it. So if I can have my first slide, Steph. So for the maintenance of weight loss, we have certain criteria that have been used quite often. Whether these are the best criteria, I don't know, but these have been used. So what we typically think about is that for weight loss, in order to maintain your weight, you have to first have lost the weight to maintain the weight loss. So we typically talk about a 5 or 10% weight loss because we know that those are clinically significant amounts. And what we typically talk about is that for the duration, the weight loss must be maintained for at least 1 year. Now, regain is much more questionable because what we often say is that some weight regain is okay if the person is still at a 10% weight loss. That means a person could lose 20% of their weight at 6 months and have regained a whole lot, but still be at 10% below and be considered a maintainer. Okay, but there have been other definitions that have been used for weight regain. In my Stop Regain study, we used a 5-pound weight regain, and June Stevens recommended a 3% weight regain. Both of those turn out to be very similar to each other, but those are some other criteria that could be used for the regaining of weight. Now, the next slide, please, Steph. So this shows you look ahead 4-year data. Now, before you look at this data, can I just get your attention for a minute? Because I would like to just tell you a little bit about Look Ahead. Look Ahead was a randomized clinical trial that involved 5,000 individuals, all of whom were overweight or obese and had type 2 diabetes. What we did was we randomly assigned these individuals to either intensive lifestyle intervention, ILI, or to a control group called DSC, Diabetes Support and Education. So one of the things that's very nice about Look Ahead is it allows you to look at weight loss data for almost 2,500 people who were assigned to intensive lifestyle intervention. So this slide shows you the 4-year data. That's what I'm going to be looking at, is 4-year data and Look Ahead. This is ILI participants who lost at least 10% of their weight at year 1, which is 887, or about 35% of the original population. Then it looks at how many of those people kept off the 10% weight loss, shown at the bottom in the lightest gray. You can see that 42% of the participants not only lost 10%, but they kept it off through 4 years. Now that's very typical for the biggest group to be the group that is maintaining whatever they originally lost. So if you look at the 5 to 9.9% data, which I have not shown you here, you can see that most people who lost 5 to 9% also maintain 5 to 9%. But this slide does show you the variability in what happens over time. I can have the next slide, please. So what makes weight loss maintenance so hard? One thing that we know is that people live in an obesogenic environment. So that's one thing that makes it hard. But there are also physiological changes that occur with weight loss. And these have been well documented by people such as Kevin Hall and others. So there are changes in energy expenditure that occur, and there are changes in appetite regulation, both of which lead an individual to regain their weight. Okay. So individual differences are critical in both the obesogenic environment and the physiological changes that occur with weight loss. So we are going to have to take an individual view. But some people do succeed in weight loss. So what predicts long-term maintenance? So again, these are data from Look Ahead, looking at that same 10% of people that I was showing you before, 10%, who lost weight and then kept it off. So this looks at their weight change categories according to their to behaviors. So this looks first at the treatment contacts in years 2 to 4. And as you can see here, the people who not only lost 10% but kept it off at 4 years had attended more meetings in years 2 to 4 than the group who gained weight or the group who had regained most of their weight. This slide shows you the calories consumed at year 4. It's a slightly different pattern because here you see that the people who regained weight over here had the biggest increase in calories, and they differed from the people who kept off their weight, but there was no differences in these two middle groups. And here you have the kilocalories of physical activity at year 4. And again, you see a third pattern, which is that all the groups differ from each other and from the 10% weight loss group. So in this study, and in many, many studies we've seen, there are 3 variables that are related to weight loss maintenance. One is going to attending meetings or self-monitoring, so adhering to your program, the diet, and the physical activity level. Next slide, Steph. So now I want to turn to what I consider one of the important questions, which is if the health benefits are the health benefits maintained if the weight loss is maintained? So over here on this slide, I show you data from Look Ahead of people who had the 10% weight loss originally and maintained it in full. Okay, that's at 40% of the people we had talked about before. This is people who lost 5 to 9% and maintained it in full. These are people who lost less weight and maintained whatever they had lost in full. And here I look at 2 physiological outcomes. There are others I could have picked, but I just picked these for examples. So this is changes in hemoglobin A1C from baseline. And as you can see, the group that lost the most weight has the best hemoglobin A1 changes, and those are maintained quite well over time. Same with changes in HDL cholesterol, which is the good cholesterol, so you would hope it would be going up. And sure enough, the group that loses the most weight in the black line is also the one that has the best increases in HDL cholesterol. And you see no evidence that if weight loss is maintained, that the health benefits will decrease over time, which had been a hypothesis that we had entertained, that even if you maintained your weight, maybe it wasn't going to be so helpful. But here it does suggest they are. Now, this is the other key question, I think, which is it better to lose more weight and regain some weight, or to lose less weight initially? So here again, I'm using data from Look Ahead, and I'm comparing 2 groups. One who have large weight losses, 10% weight loss, but then they partially regain, they come up to about 5%. And this is the group who loses about 5% originally and keeps off the 5 to 9%. And these again are the 2 physiological measures I've picked just to show you. So here's change in hemoglobin A1C from baseline. Now, hemoglobin A1C you'd like to be low. So you can see here that this group who loses the weight and regains some ends up far better off than the group who lost less weight. And the same is true with changes in HDL. The group who loses weight and regains some, shown up here, have better increases that are sustained over time than the group who lost less weight initially. So it seems like it is better to lose more weight and regain than it is to lose less weight initially. Now, so I think there's a couple of questions that we have to ask from these data. First of all, is weight loss maintenance really the best endpoint? And Stephanie's going to be talking about that in more detail in a minute, because I think weight loss maintenance is really due to individuals continuously or consistently monitoring, regulating, and adjusting. I don't believe that people stay at exactly the same weight all the time. And I think what happens is the people who are most successful watch their weight, either by watching the scale or some kind of measure, and then they consistently regulate and adjust. So as soon as they see a little bit of weight gain or a 5-pound weight gain, they make some adjustments to their behavior. And I think that's what everybody is saying in these panels. And what we really have to think about over time is how we're going to get at that monitoring, regulating, and adjusting. So Steph, and at that point, I'd like to turn it over to you.
Okay, great. Thanks so much, Rena. So I'll talk a little bit about these behaviors that we can consider in the context of weight loss maintenance. So first of all, level set on why we might care about weight loss maintenance behaviors just as much, if not maybe more than weight loss maintenance itself. So what you see here is a graph of weight loss and subsequent regain in a recent study of behavioral weight loss. And this dark black line represents the average across individual trajectories, which are the color lines. Let's say this represents the average patient in this particular sample. So first notice how slow the weight regain trajectory is for the average patient. This red dotted line represents a standard weight regain threshold defined by Dr. Wing at the start of the presentation. So something like 5 pounds or maybe 3% of weight regain. And it takes the average patient in the sample steadily about 6 months, maybe less, to officially reach that threshold. Then they're considered to be no longer maintaining their weight. But if we use this threshold to define whether or not we should implement some sort of intervention to help reverse weight regain, we're almost too late. That's when they seem to hit the threshold, but behavior change and weight regain has been happening over the 6 months preceding. So therefore, if we are tracking behaviors that precede weight regain as opposed to weight regain itself, you're looking at a much earlier and potentially much more effective intervention point. So that's why we care so much about behaviors when it comes to weight loss maintenance. So Dr. Wing reviewed all of this already, but or much of this already, but what key weight-related behaviors we know to be associated with weight loss maintenance are things like diet, physical activity, and treatment adherence. And the most important thing that we've noticed is that adherence to treatment recommendations are much more critical and more robust predictors of weight regain and weight loss maintenance. And within each key behavior on the slide here, I've got commonly cited thresholds for what we might consider recommending to promote successful weight loss maintenance. A notable snag in this is that these thresholds can look really different from person to person. Again, a theme we've been seeing across behaviors here. A threshold that works to maintain lost weight for me might not necessarily work for someone else. And I think some really interesting data that we have here, given the potentially individualized nature of some of these thresholds and criteria for people, a better or more interesting angle that we could be taking is simply trying to measure change in individual behavior patterns. So the results I'm showing here are from a paper that had analyzed data from the National Weight Control Registry. That's a group of people who lost greater than 30 pounds and maintained that for about a year, or at least a year. And we measured whether or not participants changed in how they were engaging in any of the key weight-related behaviors that we know to be related to weight loss maintenance, and then examined the associations between the number of those changes and weight regain over time. And what you see here in the graph on the right side of the screen is that fewer adverse behavior changes someone had, on average, the less regain or the slower the trajectory of regain. And importantly, each adverse behavior change compounds one another and is related to more rapid regain. So the take-home point here is that as a field, we might want to be moving more towards measuring individual behaviors and in particular detecting changes and behaviors that precede weight regain. So I'll quickly touch on this. In that regard, we have many ways that we can measure these key behaviors. And for time, I'm going to leave these up for discussion. But what I'll note is that something that is really critical in our measures is that we really want to be focusing on using technology-based tools that are so important in advancing this field, because they've really moved us forward in being able to monitor and measure variability in behaviors that precede weight change. Again, really truly informing our research on the mechanisms of behavior change and subsequently our treatments. So being able to try to monitor this variability and come up with better individualized thresholds here, using things like passive sensing and ecological momentary assessment, all of which will be covered in the next panel, of course. And lastly, I just wanted to comment on mechanisms of action. What should our treatments for weight loss be targeting and how? Here we have an hypothesized, what I like to call a simple model of the mechanisms of weight loss maintenance. The quote unquote simple version of this is that there are a myriad of personal, environmental, and behavioral factors that affect weight through their impact on key behaviors like diet, physical activity, and treatment adherence. The complicated part of this is that all of these influential factors, and of course I was not able to name all of these on a single slide, potentially influence one another. And to add an additional layer of complexity to this picture, we have good reason to believe that key mechanisms of action are different across people. So for example, mood might be an important factor influencing my diet and therefore my weight, but for another person, environmental context or structural context may be much more important or more influential. And to add even further complexity, these mechanisms of action likely change over time within each individual. So mood might be influential for me and my weight right now, but it might not be a year from now. And I believe the others have presented, the other presenters have touched on this as well, as this in longitudinal change over time in potential mechanisms of action. So there's a lot to tease apart with this quote unquote simple model. And in reality, the theoretical and conceptual models we have at present are not always adequate at representing this complexity. So when we look to the future of weight loss, of research in weight loss maintenance and related behaviors, we're really thinking about the following. We're thinking about needing more high quality methods to measure adherence to key behavioral recommendations. And particularly, we should capitalize on digital health tools to capture variability in behaviors that can help it potentially inform novel intervention approaches. In particular, what I've noticed in the other presenters versus what we know in the field of weight loss maintenance is we're still very far behind in terms of like what those individual thresholds or trajectories should look like, or what we know about them to promote successful weight loss maintenance. We need innovative research designs that match the complexity of the problem. So for example, typical research designs for developing and evaluating treatments like standard RCTs often focus on the average outcomes across groups. We might need to start using methods to help us at least account for or even solely focus on individual change in outcomes. So to think about a few, we can make greater use of engineering-inspired methods like micro-randomized trials, system identification, and or N of 1 designs. And then lastly, we need analytic methods. We need novel analytic methods that can keep up with the advancements in measurement technology and in research design. So examples here include the applications of machine learning, computational modeling, dynamic systems modeling, none of which are particularly new in their creation, but they are new in their application in some of these areas. And so there's a lot of rich research opportunities left in the field of weight loss maintenance. And I'm really looking forward to the panel discussion so that we could talk about them further. And with that, I will leave our time, and thank you so much for your attention.
Hi, I think I'm next on the agenda. Should I just start?
Yes, please.
Okay, and I apologize for not being here earlier. I'm working in the hospital, but I'm glad to be here for the time that I do have. So my name is Jessica Haberer, and I'm excited to talk to you about medication adherence in this context. And even though I had my slides totally up and ready to go, they're not there now. Give me 1 second. Are you able to see my slides?
Yes, they look great. Thank you.
Okay, wonderful. So I'm going to talk about medication adherence for prevention and what it really means to be successful in that context. And I was able to hear some of the earlier presentations, and I think one of the interesting aspects of prevention is that it's not a consistently needed thing. You know, sometimes we need to be preventing behaviors, and sometimes or conditions, diseases, and sometimes we don't. So what I'll do is talk about this in the context of HIV prevention and with a concept that I helped develop with several colleagues called prevention effective adherence. So these are my disclosures about my funding, but I have no conflicts. And what I'll talk about over the next few minutes is what this concept of prevention effective adherence is, how adherence for preventive medications differs from treatment, and what we need to know to understand if we're actually being successful in matching the behavior around adherence with the need for prevention. I'll talk a little bit about how to apply prevention effective adherence, and then some challenges and areas of research with this concept, and a few concluding thoughts. So just a few basics. I know not everybody here is an HIV researcher or clinician. So you probably do know that HIV is not curable, but we do have, at least yet, but we do have very effective antiretroviral medications. Those can be taken in various combinations that are very effective for treatment. There are different combinations and different drugs within antiretroviral medications within that class that can be used for prevention. But with either approach, the efficacy and effectiveness of these medications really depends a lot on adherence. And as you've heard, I think in some of these other discussions, we think about adherence in a lot of different ways, whether people adhere to the initial prescription for the medication or perhaps other types of therapy. Then how do they do with that prescription over time? For instance, with daily pill taking, are they taking it every day? If the prescription is to take it during certain behaviors, are they taking it during those behaviors on a regular basis? And then thinking about adherence as persistence over time, or that longitudinal use. So where I'm going to start with HIV prevention is with PrEP. So this is using, again, antiretroviral medication to prevent the acquisition of HIV infection. This is a very long time in coming, many, many years spent on clinical trials to show that PrEP works when you take it. And I was fortunate to be part of the WHO process of developing the guidelines to help people understand when to take PrEP, who should take PrEP, and how to support people in that process. So in 2015, the guidelines were being developed in Geneva, and this was the document that kind of briefed everybody on how to think about PrEP. And as you can see in the upper right, PrEP works when taken. I think that can be said broadly about most things. You have to actually use them for them to work. But this was really very apparent with the different clinical trials that led to the approval and rollout of PrEP. And so the importance of adherence was really highlighted, I think, for this type of medication. And then you can see on the left side that the recommendation was for people to use PrEP if they had substantial risk. And that's a very deceptively simple statement and recommendation, because how do we know how to do this? And what that led to was a discussion with the authors that you can see here on a paper we wrote shortly after that meeting, where we talked about defining success with PrEP through prevention effective adherence. So this table here shows you why we wanted to spell out the differences for adherence to prevention versus treatment. And a lot of this had to do with the mindset of most people in HIV at the time, which is, you know, of course, adherence is really important. You need to take antiretroviral therapy all the time. But PrEP is a different situation. It's for a situation that may or may not always be present. And that sounds simple, but again, that's deceptively simple to understand when people need PrEP or not. So I won't go through all of the different lines here in detail just for sake of time, but we laid out, you know, who needs to be taking ART versus PrEP. What does the regimen look like? And initially it was daily. It's also approved in certain circumstances for intermittent use, and that's being explored with different populations and potential routes of exposure. There may be different motivations behind treatment versus prevention. And how long do you need to take it? ART is for life at this point, but PrEP certainly is not for life for most people. What the alternatives are for getting prevention versus treatment, psychosocial factors that may influence this process, and how people are able to access the medications. So important differences between treatment and prevention. So to put this kind of more visually, I'm a very visual person, we wanted to kind of display what the paradigms look like. So for ART, again, we want adherence consistently. Success means taking medication every day, all the time. So success is the behavior completely aligned with the time on drug, and that's an ongoing arrow. With prevention effective adherence, it's much more dependent on behavior. It's dependent on risk, and it's dependent on when HIV may be in that equation. So again, very simple concept, but this gets complicated when you try to think about knowing each of those different variables. So as you may have heard from some of the other presentations, and I won't go into great detail about the specific measurement for adherence, but there are lots of ways to think about medication adherence. You can ask people questions in person, you can have them fill out forms, you can send them SMS. There are many ways to ask people what they're doing. Some work better than others, and you can think about a lot of cognitive psychology around how people recall what they've done, how they recall what they didn't do. So it's not always the most accurate measure, but it is certainly one we use a lot. Pharmacy refill can tell you if people at least have the medication in hand. We don't know if they take it, so it's a maximum predicted measure, but it can be very useful, particularly for longitudinal use of a medication. There are electronic monitors, and I believe Bernard Frins is part of this workshop and can talk more about that perhaps later on today. But essentially a smart pill bottle that tells you if it's been opened or not is a good proxy for medication adherence or ingestion. There are pharmacokinetic measures that we use a lot to look at drug levels in various matrices, you know, blood, hair, urine, and so forth. And even digital pills, where we can put an organic tag onto a pill and see when that hits the gastric juices. It sends signals to give us a very objective indication of pill ingestion. So there are all these different ways you could measure use of PrEP. But we also have to think about the behaviors. And I know other people have kind of touched on this already, but thinking about how do we understand when somebody may be having sex, when they may be having sex with somebody who may have HIV, when they're not using other protection measures, because PrEP is not the only way to prevent HIV acquisition. So we need to know about behavior, which primarily is through self-report, again, through a variety of ways, and also that context. So again, where are they, what's going on in their lives? And we may need to get collateral data that could come from their medical charts. It could come from other sources. I know another speaker talked about ecological momentary assessment. It's a way to understand, what's really going on so that we can think about aligning adherence with the need for prevention. Great. So let me give you a couple examples of what I mean. So this is a paper that we wrote a couple of years after coming up with the concept, where we talked about context in PrEP adherence. This was a sub-study within the Partners Demonstration Project, where we were looking at serodifferent couples, so one person with HIV and one person who did not have HIV, and taking PrEP over a 6-month period. I'm sorry, taking ART over a 6-month period to reduce the ability to transmit HIV. And so it's really telling us, is HIV transmission an issue or not, based on what the partner with HIV is doing with their medication, and trying to see if the other partner still needs to be taking PrEP. So what we did is we used MEMS caps. So those are the electronic pill bottles I mentioned before, to see if anybody, see when people were taking their PrEP, again, as a proxy for ingestion, but it's a pretty good measure especially for those day-to-day patterns, and to know over time when people are accessing their PrEP. And then we used SMS surveys where we could ask individuals, are you having sex? Who are you having sex with? Are you using condoms? All of those factors that could indicate potential for HIV transmission. And then also looking at the clinical data to see if the partner who is living with HIV has been taking their ART. And again, if the partner's been taking it for at least 6 months, we feel pretty comfortable that the viral transmission is not likely to happen. And so all of these factors together give us a sense as to how much risk is really involved. So just to walk you through the figure, the overall figure is telling us how many people we got information from. And then as you narrow it down into some of these other circles, this one here with the light gray, let us know that the partner had not had ART for 6 months. So there's some concern there. This circle here says that they reported having sex. So that increases the concern for potential transmission further. And then the smaller circle here with the darkest area here is where they said they were not using condoms, so for the need for PrEP. And you can see with this legend here, when using the MEMS caps, we were able to show that people actually knew what they were doing, even though we hadn't told them about this concept of prevention effective adherence. The higher the risk, the higher the adherence. Now, we don't know about the exact alignment. It's really hard to get that degree of granularity, but I think this concept, this figure here really goes over the concept quite nicely. In another analysis from this same study, where again, we were looking at PrEP use within the context of a serodifferent couple, we defined risk for HIV acquisition in different ways. So we said it was high if the partner had not been taking ART for 6 months and there was sex without condoms. We said it was low risk if they were using condoms and had a partner with more than 6 months of ART. And we said it's pretty much very low risk if they said they weren't having sex. As there's variability in accuracy with self-report. And then we played around a little bit with what we would consider sufficient adherence to actually get—
1 minute warning.
Oh goodness, okay, I'm gonna have to go faster. To get protection. And basically what I showed here is that again, the higher the risk, the higher the adherence. So there are a number of factors that we looked at to try and understand, when people were able to do this versus not. And some of them were very logical. So if people were not achieving prevention effective adherence, it may be because they didn't need it anymore. But there were other factors that suggested maybe they were at risk and really needed support with their adherence. So there were a number of risk scores that have been developed to try and identify people who need support for HIV prevention. This is a common one from an earlier PrEP trial with young women. And it showed many of the same factors that we identified in our study. But unfortunately, risk scores like VOICE have not really panned out to work very well. And there's a lot of research going on trying to understand risk. We actually found a paradoxical relationship in another trial looking at the number of doses per week of PrEP. But again, in applying this risk score to other studies, it really hasn't worked as well as we would like. So we need to think about other ways of assessing risk and understanding people's need for prevention. So one area that I'm working in right now is using sentiment analysis, which is a natural language processing technique, basically looking at word counts and patterns to try and understand behavior. And this has actually been very successfully done in a variety of behaviors, ranging from loan repayment to smoking cessation. And I looked within a trial that we ran a couple of years ago. We did a very quick kind of subpilot to see if women in Kenya who were taking PrEP would be willing to let us look at their messages to try and understand if we could predict their need for HIV prevention. And in short, they said most of them said they were quite comfortable with it. And all said they would be willing to do it if it was beneficial. And with some preliminary data, we were able to look at clusters of words that correlated with that VOICE risk score, knowing that the VOICE risk score is not a perfect measure and something we're looking to actually improve upon, but there's something there. So I know I have to wrap up, but just very quickly, we are doing this study now at a much larger scale where we're making sure we're doing this ethically and accessing text messages and WhatsApp messages. And we're looking to see at a higher volume, are we able to predict the need for HIV prevention from text messaging? So in conclusion, success for adherence to prevention is very different than for treatment. We think that prevention effective adherence is an important concept to apply for any kind of prevention, but particularly in the rollout for PrEP. I think it's been very helpful to expedite that rollout and make sure that the expectations for treatment are not applied to PrEP, which could be quite a barrier. And that measurement is needed not only for adherence, but the behaviors and the context around the situation an individual may be in. And that novel measures and novel approaches are needed, just knowing that risk is not something people think about all the time, and our ability to assess that through self-report is limited. Thank you very much. Sorry to go over.
Okay, thank you. Thank you. Thank you most proximally, Jessica, but thank you to all of our speakers this morning. I mean, I know in these kinds of settings, it's difficult to talk into a void. So I will speak on behalf of the large community of people out there and really appreciated hearing everybody. If we could get all of our speakers to turn on their cameras, and I think they're going to sort of spotlight you. You're going to end up in the center of the screen in a moment. So I'm gonna sort of begin the conversation with some questions, and then I'd like to encourage that we've got a number of questions already in the Q&A, and I'd like to encourage people. I apologize to say this. I'm going to encourage you to put questions in, even though I recognize that the odds that we're going to have time to get to all of them are very small. But as I think my colleague said earlier on, your questions are really valuable, not just here, but just more in general, because we want to get a sense of what is on your mind as we deal with these and think about these issues. And so your questions and comments are valuable, even if we don't get to them. And so I thought maybe I would start, with sort of two themes, but maybe I'd like to start with one in particular that sort of that struck me listening to the last presentation, because I think it's sort of I want to make sure I get my terms right. The prevention effective adherence is sort of introduces sort of an interesting lens to this, right? So maintenance is, or if I can use that term, maintenance is sort of successful if it's done, if the behavior is used in the moments that it's needed, and in some sense it feels like that is captured by the need for in this case PrEP is captured by this constellation of behaviors, right? So if I understood Jessica, your diagram, right, it's sort of, it's what is your partner doing? How did you have sex? What happened when you had sex? And so that the need for PrEP is contingent on these multiple behaviors. And I was thinking that's in some ways relevant to some of these other domains as well, right? So Genevieve talked to us earlier about total physical activity, which can be sort of, you can get to total physical activity doing lots of different things. And then, Stephanie and Rena, weight loss is also clearly a domain in which the sort of, if the outcome is weight, we're looking at this sort of constellation of behaviors. And so I was curious, maybe to sort of, and I apologize to put some people on the spot, so you can kick it right back to me if you want. But I was wondering, is there something in this, in the domains of physical activity and in weight loss particularly, how do we manage sort of this idea of maintenance as being a product of sort of multiple behaviors, right? Is there something in this I don't have it on my fingertips, right? But is there something in sort of this prevention, effective adherence that Jessica's talking to us about that maybe could be useful? Sort of, as I was thinking about it, it was, I need you to do a certain set of behaviors because the need for those behaviors arise, right? So it's something like, I don't need to be physically active today because I was really physically active the last 3 days, right? And so missing that is actually, it's sort of not, it's not a problem. I don't want to put it in the prevention language. I don't know. Genevieve, can I turn to you first? Can someone unmute Genevieve, please?
There we go. Okay.
Sorry about that.
Thank you for unmuting me. So no problem. Yeah, that's a really important question. And so that is an important distinction between physical activity and perhaps some of the other behaviors. Is that physical activity, if we define it as energy expenditure, then it can be accumulated or accomplished through a wide range of behaviors. So a very heterogeneous set of behaviors. Someone could be biking one day and walking the next day, and then running and going for a hike. And then so there's potential kind of comparisons one might make, or allusions to the term habit. And that did come up in the Q&A that I noticed. The idea, that, and so we kind of play around. Nobody's really talked about habit here, but this idea that a habit is, thought of as something that's contextually dependent, and it's kind of the same time, the same place. And so, but if you're looking at maintenance of physical activity, and it could be technically accumulated through a wide range of behaviors in a bunch of different contexts, in a bunch of different places, and you're still going to have the same energy expenditure, that's something that is tricky to take into account. Now, Alex, you talked about this idea that that it may be more important to maintain on certain days than others, or kind of getting at this idea of preventing when there's risk factors. And so I think that's where thinking about what's going on underneath the surface, these psychosocial processes may really matter. So, for example, someone who's trying to maintain behavior and their context changes, so they're on vacation, or they move to a new apartment, right? And so they may have a shift. They may have to shift what they're doing in order to be active. So where it may have been more a routine or habitual to be active when they're not on vacation, they're going to the gym every day, but now they're on vacation, they have to go through all these more deliberative processes. So in that case, the prevention is more critical, to avoid completely just backing away from all your exercise for a week and a half when you're on vacation. It may be hard to get back. So in that case, that may be more critical to deploy various strategies to maintain behavior when the context changes. So that's an example I can think of from physical activity.
And I can also hop in too, because the diet literature is very similar to the physical activity literature, in that, to lapse from, or to slip from, or to go off a diet plan is extremely heterogeneous. It could involve overeating, it could involve eating a different type of food. The different behaviors that are involved in that are very distinct. And what we found in our studies is that those behaviors aren't always when you look at lapses generally, yes, they're related to weight loss and weight loss maintenance. But when you look at those specific behaviors, those are very differentially related to weight loss. So sometimes like overeating, for example, or eating at like a time where you hadn't intended, is more often related to weight loss than maybe some of the other behaviors that we had thought of as being conceptualized as lapses from a diet, for example. And what we've found even more so is that these constellation of factors, these like psychosocial factors that underlie those behaviors, tend to be really different across individuals and even within individuals over time. So there's this like really interesting pattern emerging where the behaviors are the actual, slip itself is heterogeneous in its composition, and those different behaviors that underlie it are differentially related to weight change, and the psychosocial factors are very time varying that underlie the behavior for each individual. So it's really complicated, and what we're trying to do right now is we're trying to tease that apart using methods of behavioral phenotyping, and really relying on some of these digital health tools to try to parse out some of that like very granular levels of variability in behavior and the psychosocial factors that underlie it.
And I wonder if what we're all saying too is that a slip is not always a slip, or a lapse is not always a lapse, that one person can go off of their diet and then catch right back on. Another person may go off their diet, and that may really be a bad prognostic indicator. But I think that's really why we have to get much more individualized too.
So, and I was curious, Jessica, if I can ask you, I know we have you just for a limited period of time. So, how do you feel? I mean, do you see this sort of this framework that you've developed for PrEP? Are there discussions about using it are there discussions about, is this very much specific to PrEP, or is there discussions about using this in other behavioral domains? And to think about sort of successful maintenance of behavior?
Well, I have to say I'm very much immersed in the HIV world, TB to some extent too, but I'm really excited by your idea, Alex, of trying to think about this in other contexts, and just listening to the other speakers talk about it for diets, or, in many different domains. So I would love to continue that discussion, because I think there are lots of applications. And as I kind of hinted at a little bit, I think these simple changes in how we think about when people need to do what really have a huge impact on the ability to implement whatever we're trying to do. And that may be an individual's perception of a big ask, depending on what the context is, or from a policy perspective. And we've certainly seen that in HIV, where, there's only a certain amount of money for HIV. Is it going to treatment? Is it going to prevention? Do we have a good understanding of what adhering to PrEP really means? And I think that would also apply to other contexts as well. So I would love to have those conversations.
And maybe I wanted to note one thing at the outset, because I thought it was interesting here, is that this is a rare moment where I think a lot of these conversations may be happening, within our behavioral silos, in some sense. The PrEP people are talking to the PrEP people, and this is sort of a rare moment where, and I really want to just recognize and appreciate it, where all of you are talking about similar kinds of issues and challenges across these very both similar and different domains. And one of the things I think that was most striking to myself and to I think the people in the audience is sort of the similarity of those challenges, but also the differences. And I'd like to go back and ask a question of Megan, because I think I think tobacco is in sort of an interesting place, right? It's like Megan was, and I apologize if I misstate this, but Megan, in some sense, was the one speaker who said, okay, look, our professional organization has a set of guidelines that we have developed and published, right? And a lot of, the other groups, people talked about, well, there are conventions, right? This is what we tend to do. This is what we sort of, and I was wondering, Megan, if you could speak, is that, and then I might turn to the rest of the group, how is that developed? Why do you think that's the case? And if there is a thought in some of the other speakers have thoughts about whether that would be a useful thing to develop as well. In other words, should a process for developing guidelines around, maintenance be a useful process in other domains?
So I can speak to how tobacco managed to do it. We're a small group. We're growing, but tobacco scientists are a relatively small group, and we have one basic society that we all tend to, especially the treatment scientists, tend to belong to. And I'll be honest, I was on the board of directors for the society when we decided we needed to update these recommendations because of the changes in the field. And so when you bring experts together who've done this for a long time, and again, it's very different, right? All of the other speakers spoke to the complexities of their behavior change and all the different nuances and what's acceptable and how things can trade off. Tobacco is different. You're not supposed to smoke tobacco, right? We don't want you doing it. We don't want you doing it at all. It's a very clear line. And so it makes it a lot easier in some respects to determine what is appropriate maintenance, but then there are all the nuances of which product you're using and how long you've been doing it. So I guess, from being inside of a scientific society, I feel like that's a wonderful way to bring together experts in the field and to get consensus, and maybe not consensus around the answers, but consensus around what the key components are. So you'll notice in our recommendations, it wasn't everybody do X. It was, okay, we really want you to do X. Y and Z would be really important too, but we recognize that other things are going on. So, I guess that's my not so short answer about, tobacco is different. And then we have a set standard, but it's the scientific consensus building and the opportunity of scientific societies to be conveners to try to provide some guidance that I think is helpful. And it's very possible that the rest of you are part of societies that are doing similar things.
Alex, I hate to jump in here. I get
go
back
ahead.
to board rounds. So anyway, thanks so much for including me.
Thank you, Jessica. Yes, no, I appreciate that.
I wonder if I could just add on to what Megan said. Megan, that's so helpful. I was going to ask that same question. I'm glad Alex asked it. For the rest of you, how did your field come about this? What was the process? Because that is definitely a challenge in the physical activity field. And one thing that I think the field's been struggling with, and we've been struggling with, is whether the determination of these definitions should be empirically based, or I should say more data driven. Like purely ground up data driven. So for example, we can say, how long should physical activity be maintained before, let's call it maintenance? And you can look and see, like in terms of ROC curves and predictive validity, if they maintain at 7 days, they're likely to keep going for the next 25 days. If they maintain it, but they have to maintain it at least 14 days. And that once they get to that point, then it's likely they're going to keep, it can be very data driven, right? And so we can kind of take almost an engineering, like an approach to this, or we can do, top down and say, well, we think 30 days is an important, we think 7 days, we can just kind of pick a number out of there, right? And just apply it, right? And then see what that means, right? And so it's the bottom up and top down approaches that I think it's challenging to figure out how to incorporate both, right? Because at some point, if you're so data driven, then you start to run into this fact that it's kind of different for everybody. That was something that Rena brought up, that it's so idiographic. Like for some people, if they can just do the behavior for 14 days, they're likely to keep going forever, right? Some people, they need 90 days, to do the behavior, and then they're likely to keep it. And so that's where you run into this bottom up approach, a data driven approach. So I'm really curious, the others, how, what your thoughts are on this.
And I can chime in. One of the things that I think about for smoking cessation, Megan, why do we use past 7 days for our point prevalence abstinence? And so it's kind of like one of the gold standard outcomes in clinical trials. And I'm glad that we do it, and it kind of makes sense. It feels good from a gut level. 7 days, but it could have been 6, could have been 8, right? But I don't know if you have any thoughts about that in relation to what Genevieve was saying, that some of that's probably a top down, especially with the initial group back in 2000 with Sharon Hall who developed these. But I don't know if the second iteration in 2020 tried to use more data to say, yeah, we want 7 days, 7 consecutive days of not smoking is considered point prevalence abstinence at that time point.
And that's a great question, right? And you'll notice that in the question, it was 7 days or 30 days, right? Epidemiology research tends to focus on 30 days. Treatment research tends to focus on the last 7 days. I think 7 days has more relevance when you're trying to biochemically confirm abstinence, just in terms of how, the half-lives of the biomarkers. I also think that there was at one point, whether it was empirically informed or more theoretical, the notion that if you could get out 7 days, you were almost halfway through to where the withdrawal period would be the worst. And so that might actually suggest that you've established initial abstinence, and then it would be looked at like then you'd really be looking at a lapse or a relapse versus somebody who was never able to establish abstinence. But I think Saul Schiffman's integral work in terms of identifying, so we have milestones, right? So initial ability to establish abstinence, and then once that then you can lapse and you can relapse. But again, is there something magical about 7 days versus 8 versus 10? No, but it also is helpful in terms of what participants can tell you, right? They can tell you in the last week, and they may think about 6 days, they may think about 5, but I think it's part of creating a rubric that the participants can track when you're asking about it. And I think to that notion, Genevieve, that you were talking about, how do you pick it? Here are some guidelines, and here are sensitivity analyses. Here are different ways that you might also want this as well as this. Recognizing that, as you say, for some people, it might be that you need it for a week or a month, or some people need 90 days. Well, you're never going to get everybody. But if you can take 80%, maybe 80% of people, if they can get for a month, it really does show that they're going to be able to maintain that. Is that a sufficient threshold based on whatever data you have?
Do you think it's easier to define maintenance or look at all these constructs with an all or none behavior? I would think so, and that's what you've got in smoking. You've defined it now as all or none, really.
Yeah, and it does. It makes it a very different question versus what the rest of you are trying to figure out. When you were showing those graphs about the proportion of weight gained and lost, and that all of those are dose related to health outcomes, then you're dealing with a continuous measure, and how, what analytic strategies do we have to pick a cut point, if there are any?
I just want to make one other comment too, that we're all talking about behaviors that we have a lot of trouble maintaining. But what about somebody who decides that they want to be a vegetarian and then maintains that behavior for the rest of their lives? Or someone who is Jewish and decides they want to eat kosher, maintains that behavior for the rest of their lives. Those usually have different motivations than what we're talking about. Those are not usually health, usually religious type of motivations. They're closer to all or none, I think, in the sense that a person, really feels like they must follow that all the time. But I think that's one thing that we should be thinking about. Flossing of teeth. Is that one that is an all or none? I don't know. Is that one where once people start doing it, they really keep doing it? I don't know if that's a good one. But I do think those other two diet ones are very different than weight loss diets. And I don't know quite why, or, what underlies that difference in maintenance.
And maybe another distinction to think about, and of course we're about to run up against the clock here, but is the extent to which the criteria should be sort of nomothetic or idiographic, right? And so when I think there's a, there's a way in which not the all or none also has that, right? That sort of seems like in tobacco we're pretty comfortable with this is the criteria and we're applying it to everyone. I think I would say all our other speakers sort of it's either unclear or it almost feels like it's a little bit more of an idiographic approach, right? And so how do we, if it isn't nomothetic, if it is idiographic, do anybody want to talk to this? How can we approach sort of a science of the study of behavioral maintenance when the criteria for maintenance is shifting dramatically from person to person?
Yeah, that is a really, really tough question. So definitely, I mentioned it briefly about an idiographic approach to physical activity maintenance, given that somebody could be doing all that they could do. And we know that from the empirical data that there is doing some activities better than none, right? So we don't want to have a public health message that says if you don't attain 150 minutes of physical activity per week, don't do, there's no point, you're failing, right? So if someone can do 60 minutes a week, if someone can do 100 minutes a week and they can maintain that, right, that's probably better than trying to do 160 or something over the threshold and then failing at that, right? So
why is that better? Weight loss research showed the opposite.
Right. Well, because the idea that it's better than nothing, or it's better than not at all, right? It's better to do 100 minutes. It's better to do 60 minutes than hardly any minutes, right? So that's why there's health benefit. It is a dose response, right? There health benefits from being active 60 minutes versus 10 minutes a week, right? So it's because it's a dose response, it's hard to find, so we have to either figure out, it could be potentially tailoring and trying to figure out for that individual, what is feasible and maintainable for them, right? So do we have to kind of tailor what an intervention or finding a level of activity that they can fit into their schedule and maintain regularly. And then let's define maintenance for them, success as maintaining that level, right? But that's very idiographic.
And I think this is a place too in the weight loss maintenance literature where like the research doesn't always like match up with what we do clinically, because like Genevieve, that's like sort of what we do when we sit down with a person and we're counseling them through weight loss and we're counseling them about what regain looks like. We sort of set that threshold with them and we like review things with them weekly, and we really like iterate often, like when you're doing one-on-one counseling, of course, not talking about more like standardized or like online approaches. And we teach people to sort of stay within a threshold, and we teach people to monitor. And that's why monitoring is so important in the treatment. And it doesn't always, from patient to patient, we have these like averages, but then we modify them. And there's not really like a process to capture that in the research, which is why whenever we set these thresholds, we're like, these are just averages. These are just based on what we know of averages. And so when we think about some of these idiographic like research designs and these different tools, that analytic tools we have now, like that's one of the reasons why I mentioned things like N of 1 and like engineering inspired designs, is those are really designed to get at the idiographic nature of the problem and more mimic kind of like what we do clinically, as opposed to the research world where behaviorally we have been really focused on average and nomothetic levels of things. So just to comment that really does map on to like what we are doing clinically.
Okay, I am.
Well, and I just
go
want
ahead,
to chime
Megan.
in one other
Please.
comment. And so we do some of that with tobacco research too, right? If someone doesn't want to quit, we ask them, are they willing to cut down, and would they set a goal? And so sometimes the outcome we have is, did you get to 50% reduction? But sometimes the other outcome we use is, what was the patient's goal and did they achieve it? And so there might be a goal that we have that empirically we think is where we're at, but there might be another really key outcome, which was, what was the patient's goal? Did they get to their goal? Did they maintain their goal? Being understanding that some people's goals are very different than others, but if it's goal maintenance, then again, that brings in a whole different set of constructs, right? In terms of how you maintain your personal goal around whatever behavior change you have going on, regardless of whether or not it's actually the goal that's appropriate to make the best health changes that you could have.
I think that's a great comment. And it also ties to something that we're obviously not at this point, not going to have time to get into, but a number of you raised this notion of whether we should be looking at a larger constellation of indicators, right? That there's the behavioral performance, but there's also the psychosocial variables, perhaps the subjective experience. Adam's sort of notion of the concept of sort of perceived recovery as a marker of where a person might be, and we might think about those as being key indicators, and also possibly that, I think as Megan was describing, they could dissociate, right? We could maybe clinically want people to be maintaining a particular thing, but find that individuals are actually for themselves, for their own goals, maintaining a different, a different pattern, and so in some sense they might not be maintaining in terms of what we want, quote unquote, but in maintaining in terms of what they hope to achieve and accomplish. We have a break that's a little bit already behind us. So let me take the opportunity, because I have the microphone, to sort of thank all of our speakers for their contributions, their presentations, their contributions to the conversation. We are going to come back in, well, I think Sydney's going to kick in here in a moment and tell us exactly what the time frame is in terms of the break. But I do want to note that we're going to have a panel, we're going to have a second panel following the break, and then an opportunity to bring all of the speakers back to have a larger discussion about the issues that have arisen today. And so I hope we can continue some of these conversations after we hear from our presenters this afternoon. Sydney, do you want to take over here?
Yes, thanks, Alex. So we're actually a little bit ahead of schedule, but I think that's great. We could all use a bit of a break. So thanks to everyone for an excellent morning. Thank you to Alex Rothman for moderating our first panel session. We're going to take about a 25-minute break, and we'll resume around 1:45 Eastern time here in the same Zoom link. And when we come back, we will start our second panel session, which will be moderated by Dr. Andrea Mendoza-Vasconez. The second session will be on moving from definitions of and criteria for maintenance to application, innovative tools and methodologies to monitor behavior maintenance in the context of daily life. So thanks again for your engagement so far, and we'll see you back here at 1:45 Eastern time.
Hi, everyone. We are right at 1:45 East Coast time, and hopefully everyone is coming back from break and had a chance to get up and stretch and take care of things on this break. We are excited for the rest of the afternoon with you. I want to thank everyone for posting questions in the Q&A, and just give a reminder to continue to post your questions in the Q&A throughout the rest of the presentations. That includes any other panelists or presenters. If you could also put your questions using the Q&A function, that would be great. We have an exciting afternoon, including our next panel on innovative tools and methodologies to monitor behavior maintenance. We will have 4 speakers and then a break with the opportunity for a moderated discussion with all of our panelists after this short break. I am now happy to turn this over to our moderator for this next session, Dr. Andrea Mendoza-Vasconez. Dr. Mendoza-Vasconez, you could turn your camera on. Great.
Hello, thank you. Yeah, thank you very much. So my name is Andrea Mendoza-Vasconez. I will be the moderator for the second panel. And I am really excited. We have put together an amazing panel of experts who will be talking about moving from definitions of and criteria for maintenance to application, the innovative tools and methodologies to monitor behavior maintenance in the context of daily life. And for the sake of time, I'm not going to go through each of these speakers' bios, but feel free to go online to the event website and look them up. So we will be first hearing from Dr. Tyler Mason about ecologic momentary assessment. Dr. Bernard Bridgens, he's going to be speaking about electronic adherence monitoring. Dr. Chad Stetcher will be talking about sensors, wearables. And Dr. Bonnie Spring will be talking about leveraging and harmonizing multiple tools. And then we will take a break at 2:45 p.m. and we will come back at 2:55 p.m. for a moderated panel discussion. So with that being said, I'm going to pass it on to Dr. Mason.
Hello, everyone. Hopefully, let me go back. Okay. I'm happy to be here today to talk about ecological momentary assessment, or EMA, for use in health behavior maintenance.
Tyler, if you could swap from presenter view to swap your view, that'd be great. Thank you very much. Perfect.
So I'll be talking about EMA for health behavior maintenance. And today I'm going to describe ecological momentary assessment, or EMA, and then I'll talk about use of EMA to understand behavior maintenance. And I'll talk about some key challenges and some key opportunities or future directions in using EMA to understand behavior maintenance. Okay, so I first wanted to describe what EMA is for those that may not have this knowledge. And so this is a method for capturing naturalistic data using mobile phones. And so what we do is we have people complete surveys on their phone for usually 7 to 14 days as they go about their life. So they're doing this in their own lives, just as they're doing their regular tasks and things they do. And so each day during the EMA, they receive semi-random prompts to their phone throughout the day. So these are typically stratified within semi-random sampling windows. So they may start at 8 a.m. and then go all the way till 11 p.m. And they may receive usually between 4 or 5 signals a day. And then during these signals, they're completing measures of their behaviors, their context. So where are they located? Who are they with? How are they feeling? And they're completing these same measures at each of the EMA time points so that we're getting a lot of fine-grained data about people's behaviors and contexts. And so, as I mentioned, this continues for about 1 to 2 weeks typically. This continues for about 1 to 2 weeks typically, but can go for even longer, such as a month or longer than that. And there's numerous strengths to using EMA. The first is that it occurs in real time, which reduces self-report biases. So as we know, people's memory is not the greatest, and people have a really hard time remembering things, even in the past day, but certainly when we're talking about weeks and months, they really aren't able to accurately remember their behaviors. And so in EMA, we're asking them right now, how do they feel? Right now, what are their behaviors that they're engaging in? And sometimes there's a little bit of a window of recall, like in the past 2 hours, but typically we're getting really data that's really close to the experiences. Another advantage of EMA is that it occurs in the real world. So it's occurring as people go about their daily life. And this increases the generalizability to people's everyday lives and contexts. And we can actually measure how their context right now affects their behavior. So where they're located right now, how is that affecting their behaviors? Who are they with? Who are the people that they're with right now? How is it affecting their behaviors? How are they feeling right now? How is it affecting their behaviors? And then the last strength that I'll talk about is the ability to look at temporality. So at 3 p.m., I can assess how upset someone is. And then at 6 p.m., I can ask them about their behaviors. So, for example, to what extent they felt they overate. And then we can see how upset they were at 3 p.m. Did that predict whether they engaged in overeating at 6 p.m.? So we're looking at these kind of time-lagged, momentary relationships between our variables of interest. And so EMA has been used for many, many different behaviors. I've listed some of them here. Obviously, some of these have more research done on them, whereas some are kind of emerging behaviors that are being studied with EMA. Some of the most common ones as far as behavioral maintenance and lapses are diet and nutrition and smoking. So I'll be focusing on those behaviors for the rest of this talk. So this is an example of maybe what a typical day of EMA might look like. If we look at the left side of this, so that might be when somebody wakes up, and then the right side is when they go to bed. So during EMA, they may receive 5 prompts across the day, and that each of these prompts, they're measuring what behaviors they engaged in, as well as the other contextual factors that we're interested in. So an EMA prompt, we might ask somebody, did they smoke? What did they eat? Did they engage in physical activity? And then we ask that at every prompt after that. You'll notice that the prompts are not evenly spaced, and we do that because we don't want people to be able to predict when the EMA prompt is coming. So that kind of gets rid of that ability to kind of like plan what you might say during the prompt, because you don't know when it's going to happen. But we do we space them semi-randomly, so we usually have windows that an EMA prompt might occur. So that makes sure that we get the full day, because we want to make sure that we also get the full day's time. And then I'll also say here that in addition to these random prompts, we can also have what's called event contingent prompts. And during these event contingent prompts, we have people actually open up the EMA app or whatever we're using to give the EMA, and we have them record their own behaviors. So if they engage in the eating episode, we might say, okay, pull out your phone and record what you ate and whatever the other questions that we're asking. The only limitation to the event contingent recordings is that we really can't know if people didn't report on a behavior that they were supposed to report on, though we can also ask in the semi-random prompts, did you forget to record a behavior? So we kind of have two opportunities to get these behaviors in the random prompts as well as the event contingent prompts. So how do we assess lapses in behavior? So a few ways that these lapses can be assessed is, first, we can rigorously define at baseline what we mean by a lapse in behavior, and then train participants on that definition and how to report that in EMA. So one example from a previous research study, they said for dietary lapses, they defined it as eating or drinking likely to cause weight gain and or put weight loss maintenance at risk. And so participants were trained at baseline on this definition. And then during EMA, they were asked, did you have a lapse? And so they were supposed to use this definition to know, okay, what happened fits with this definition, so I will record that as a lapse. And then I believe in this study, they asked further questions if they said yes about the lapse, but that's essentially how they defined whether someone would report a lapse in EMA. Another type of way to assess lapses is to first ask about temptations in EMA. So studies have, they'll ask, did you have a temptation, in the past 2 hours or since the last prompt? And then they would say yes or no. And then if they said yes, they would follow that up with the questions about lapses. So if you had the temptation, did you give into the temptation or did you have a lapse? And so that kind of allows a little bit more different definition of lapses than the training one. Another example is smoking. As was mentioned in the previous discussion, smoking can be a little bit easier to measure because just smoking is seen as a lapse. So in this study, they just said, since the last beep or recording, have you smoked? And that would measure the lapse. I research binge eating. And so in our studies, if someone, similar to smoking, if someone engages in binge eating, that would be a lapse. We don't need any further information about that. Okay, so there has been a great deal of research in smoking and diet with lapses, as I mentioned earlier. And so there has been a few meta-analyses and systematic reviews that have been done on understanding contextual factors associated with lapses. I won't go into too much detail, but this study found about 60 studies which measured lapses after smoking cessation treatment. And what they found was that craving and social and environmental cues were the most predictive factors associated with smoking lapses. And they didn't find evidence for affect as a predictor of lapses. And then this is another study in weight loss dieting, and they looked at appetite and affect as predictors of lapses. And this is a systematic review, but they did find that there was some emerging evidence for affect and appetite as predictors of weight loss lapses, so dietary lapses. Okay, so now that I've talked about what EMA is and how it's been used in lapse research, I'm going to talk about some of the key challenges to think about when you're designing an EMA study to look at lapses. And these are compliance, balancing depth and breadth of measurement versus burden, and then self-report biases. So with compliance, it's really important that we have good compliance in EMA. So when you have bad compliance, we start to think about the sample being very biased. So why aren't people completing the study? Why are the times that they do complete it, are those biased measures of that are very different than the times they don't report it? So we really want to have good compliance. And then 80% is typically like the gold standard in EMA research, although that's not really like a data-driven number. It's just kind of what the number that people look for. But of course, higher is always better. There has been a review on compliance in EMA. They actually found that children and adolescents had a lower compliance, around 70%. So you might see a little bit lower in children and adolescents, and that seems to be consistent with the research that's been done. So I can't give you an exact number for what we need for compliance, but typically when you have less than 50, 60%, that's when we start to think about potentially having biased data. So it's really just reinforce that it's important to have good compliance. And then how do we increase compliance? Of course, money is really important for increasing compliance. Studies that use EMA typically have a couple different ways that they use money to increase compliance. So you can have a base amount that you pay people for completing the EMA. So that might be $60 for completing the full EMA protocol. And you might pick that number based on, how burdensome it is or how the length of it. But then you also might want to have a compliance bonus. And so this is extra money that they get for completing a certain amount of prompts or a certain number. And so oftentimes what we do is if you have 80% compliance, you'll get maybe an extra $20, $25 compliance bonus for meeting that goal. I've also seen $1 per prompt used. So every prompt you complete, you get $1. I've done that in one study and that was very effective. So you really want to think about how can you, use money to increase compliance. And yeah, that's just really important. The next one is training. So we really want to make sure that we train our participants on the protocol very well. So they know exactly what they're doing, how to complete prompts, when they're doing prompts and everything like that. It really helps to increase compliance. Ease of participation. So
1 minute warning.
Okay, so also we want to make it as easy as possible for people to participate. And then we also can enroll with a caregiver for child studies. So oftentimes we want to know a lot about behaviors. So for example, with eating, we want to know portion size, what they ate, but we want to make sure that we balance that with how the burden of completing these questions can increase or decrease compliance. And then there's also self-report biases. So we want to minimize recall. We want to integrate sensors, which somebody will talk about later. And then if we can have training and examples and definitions, that really helps to make our data better. Some opportunities for future research, using longitudinal multi-wave EMA. This can help us understand how mechanisms of lapses might predict future outcomes. A lot of the studies so far have not really integrated theory into their studies. So really, we want to design EMA studies that are drawing on really rigorous theories of why they believe these factors are important. And then novel interventions are important. So just an example of novel interventions, these are sometimes termed just-in-time adaptive interventions or JITIs or ecological momentary interventions. And they use information gathered through EMA to target the processes associated with lapses, sometimes called critical moments of intervention. And just an example of this, oftentimes we find that stress predicts the greater probability of a lapse. So we can intervene after somebody reports stress, and then this can decrease the probability of lapse. So that's kind of an example of what a just-in-time adaptive intervention or EMI might look like.
This concludes my presentation.
That's the end of my presentation. Thank you so much.
So now we will hear from Dr. Briens.
Okay. Good afternoon, and thank you for the invitation. It's a pleasure for me to talk about electronic adherence monitoring. I assume that you see my slides.
Yes, we can see that.
Okay, perfect. So the behavioral domain is medication adherence, and we have defined medication adherence as the process by which patients take their medication as prescribed. And we recognize that this is a dynamic process over time with many fluctuation in most of the patients. But there are 3 key elements that we have to recognize in medication adherence. Once there is a prescription, the patient has to initiate that treatment. That's the beginning. Then he has to implement the dosing regimen. That means taking it once a day, twice a day, with food, without food. And when we think about polymedicated patients, this implementation can be pretty complex. And finally, the patient has to persist with treatment for a long period of time, particularly in chronic diseases. So what can go wrong? Either the patient does not initiate the treatment. That's typically a binary outcome, a yes/no. Either the patient delays, omits, takes extra doses. That's a dosing history. Or the patient discontinues treatment too early, and that's a time to event. Those 3 elements are very different in nature. There are different forms of medication adherence, and you will see that during my presentation, So the next, I have some trouble. Okay, so the next is electronic adherence monitoring, and it's increasingly called digital adherence monitoring. And what we have in terms of digital adherence monitoring, it's often a combination of hardware and software. So on the left-hand side, we have a set of hardware, a set of smart and connected packages and devices that will capture in real time when the patient access the medication. There is the well-known MEMS cap here in the middle, but since the early days, we have a wide range of packages that can capture that information in real time. And this is connected to a set of software that allows to process the data and make sense of the data, which can be a cloud platform as well as a mobile application. And depending on the context, different combination of hardware and software may be useful. And some approaches are relying only on software, like a mobile app, for example, for an e-diary. But we strongly believe that the combination of both, an appropriate combination of both, is the best way to capture this behavior of medication intakes. So this is an end-to-end solution for managing medication adherence. And I would like to remind you that the problem that we are trying to solve here is that some patients don't take their medication. They don't do something. And that's why the most passive is the measure, the better will be the measurement. For example, smart packages are extremely passive. You just capture, patients has nothing special to do. It captures automatically when they take the medication. While when we ask an action to the patient, like app-based diaries, as soon as you start to ask something to the patient, they may not do it, and you don't capture that information, you don't measure the behavior. And it's even worse when you do a session-based measure, like, for example, app-based video recording, that will decrease the reliability of the measure, and particularly, you will not get the measure in the patients who don't do it. And as soon as you move away from passive, you will get the data in less and less patients. With electronic monitoring using smart packages, we do have good experience, and there is a wide literature, over 850 peer-reviewed papers reporting the accuracy of this type of approach. And in drug trials, where it has been mostly used today, we have 97% accuracy. So the type of data that we are collecting is illustrated here for one case study. So on the x-axis, you have the days of follow-up in the study. On the y-axis, you have the time of drug intake. And every time there is a blue dot, it's a dose taken. Every time there is a gray line, it's a missed dose. So you can see typically how a patient can change behavior over time, here over a bit more than 1 year. You can see here, he takes all the drugs, all the medications, all the prescribed medications, but within a wide variability in time, then miss a few doses, interrupts treatment, starts again pretty early in the morning, pretty consistent, miss a few doses, miss more doses, starts again pretty well, interruptions again, miss a few doses, and so on. And this is the case of most of the patients, even in clinical trials. What I didn't tell you is that this patient here, the one we just saw before, took exactly 81% of the prescribed doses. And very often in medication adherence, there is this unfortunate rule of 80% is enough. So that's why I decided here to plot the 6 patients who are the closest to 81% in our database. And you can see the 3 on the left-hand side are once daily dosing, the 3 on the right-hand side are twice daily dosing, but all of them show very different behaviors. The ones we just discussed, one here stopping too early, one here missing doses at random, one here on the right-hand side where there are problems primarily in the evening, one with problems at the beginning, and one with deterioration over time. And first of all, we can expect very different clinical consequences of those non-adherence. But also imagine that you have those patients in front of you and you can engage in a focused discussion. The message will be totally different. You may decide for this patient to say, oh, look, most of your doses are always on weekends. Can we solve the weekend problem? While here, the patient is discontinuing treatment too early, and you have to identify the reason why there is a discontinuation. So that's why this feedback will be very focused if you have reliable data. We have measured this type of this information in quite a lot of clinical trials. In the previous slide, I mentioned 200 clinical studies. Here, this is a publication we did about 10 years ago, and we measured 17,000 patients almost from 95 drug trials, well-controlled clinical trials, using smart packages. And you can see in those trials, first of all, here on day one, you have 3 to 4% of the patients who are highly selected to join those trials, and they never open the package. And then over time, you will see that you are losing more and more patients. And after 1 year, about 40% of the patients have discontinued. Among the patients who are still engaged, here in red, you have the adherence curve. Those are the proportion of patients who do it as prescribed. So the difference between the blue curve and the red curve, those are the patients who are engaged, but they don't do it as it is prescribed in the protocol. So that means constantly over the trials, about 15% of the patients every day don't take their medications as prescribed. And we do see wide differences across therapeutic areas, and it is in depression that we see the worst adherence, clearly, and the worst persistence. And this translates in the newer study we have done in life-threatening diseases like oncology. We do see major problem of medication adherence as well. What I want to stress here is that we have most of the studies, drug development studies, are running for maximum 1 year, while when we are in real life, patients are followed for much longer period of times. However, in drug trials, this type of measures, the type of measures that are currently implemented in drug trials, PK, self-report, and pill counts, are extremely sparse, biased, and unreliable. And so the problem of medication adherence in drug trials is poorly diagnosed today, and often it leads to the development of drugs at doses that are too high for adherent patients. And that may have consequences when we will manage adherence in medical practice. When we have to monitor patients for a long period of time, the only way probably to detect non-persistence, and this was already mentioned by Jessica before, is using pharmacy refill databases, because there we can detect where a patient disengaged in real life from a treatment or a class of treatment. But when we want to monitor very precisely the implementation of a dosing regimen, electronic monitoring is the gold standard. It's also the gold standard in clinical trials for initiation and persistence, but in medical practice, this becomes a real challenge, as I will discuss in the next slide. But it remains a gold standard for measuring precise implementation, precise medication intake behaviors. And the real challenge we see is that today electronic monitoring has been primarily used in drug trials, in research settings, where the focus lies primarily on the investigational drugs. The challenge is when we go to real life, to daily practice, where the focus lies on the patients, and very often with multiple conditions. So the difference is that in trials, you follow the patients for a few weeks, a few months, lifelong, sometimes in real practice. There is a defined beginning and a defined end in trials. It's not the case in practice. There are very well scheduled visits in drug trials. It's variables visit schedules in practice. There is an investigational package in trials, and there is a wide variety of packages and weekly organizers who are widely used in clinical trial, in daily practice. In trials, there is a main investigator, it's free of charge. In practice, there are many HCPs, physicians, specialists, GPs, nurses, and there is the cost of care for sure. And also it's much easier to integrate in drug trials. So those are really the challenges to make a success of electronic monitoring from trials to medical practice. In the medical practice, the principal objective is clearly to manage medication adherence. And if we go back to the timeline here from initiation, implementation, persistence, We have also to realize that motivation is changing. At the beginning, the patient is clearly in a highly reflective mode, usually, why I'm sick, why I'm getting this medication, is this the best medication for me? And the objective is really to put the patient in an automatic motivation, building a strong habit of medication taking, so that we hope that he will persist as long as possible. And we have defined the management of medication adherence of the process of monitoring and supporting the patient throughout that journey. And it's not a patient's problem, it's really a system problem. Healthcare system, provider, patients, and their social network should contribute in that management. But the objective is clearly to achieve the best use of appropriately prescribed medications to maximize the benefits and minimize the harm, because that's very different with the other behaviors I think we have discussed earlier today, is that there is a strong pharmacometric link to medication adherence, and we want to maximize benefits and minimize harms. In this management of medication adherence, in my view, there are two promising ways of managing adherence. And one that we have shown that to be very effective is feedback. When we can feedback information to the patient, talk about his past behavior, we can change the future. And we have an improvement of up to 20% in medication adherence by doing that feedback. There are two reviews of the literature here, and they are very similar in the outcome. We can change his behavior by doing feedback. The question is still how to do that feedback. In trials, it's very easy. There are visits, and investigators can talk to the patients about their data at those visits. How do we do that in practice is a challenge. And the second aspect is building the strong habit of medication intake. And the cue, the routine, the rewards are very important. And I'm very pleased to see that there are a lot of literature coming out those last years about habit building, because I think it has been poorly used in the past. For example, most of the application that you can, if you Google for application for medication adherence, they will do time-based reminders for cueing the patients to take the medications. While what we see in our data is that very few patients are time-based. More patients have a cue that is event-based. They take it when they get up, they take it when they take the first coffee, the breakfast, and we see much more variability in time that allows the patients to have an event-based cue. And forcing patients to be time-based, I'm not sure at all it will improve medication adherence. And the same for the routine and the reward. I think it's important that it is also personal to the patients. And that's also what I wanted to say. And for sure, there is an interaction between feedback and habit building, because that the feedback and the measurement will allow to plan the habit, to check that the habit has been executed, and to reinforce the habit. Finally, two last slides. I wanted to say very often when there is a medication prescribed, drug developers and physicians, they believe the patient is taking the medication every 24 hours as it is expected here and as it is plotted here in red. And the drug exposure after a few days will achieve a steady state, and we hope the patients maintain that steady state over time. And particularly, we hope that he is in the therapeutic window, high enough to have efficacy, not too high to avoid safety issues. But this is an ideal situation. Most patients are like this one. They miss a dose, they miss another dose, they realize they miss a dose, they catch up with taking an extra dose, they have a little weekend holiday, a longer holiday, and you can see that there is much more variability in that exposure process, which can occasionally lead to toxicities, periodic loss of effectiveness, and emergence of drug resistance, particularly in infectious diseases. And so there is the behavior and the behavior maintenance, but there is also the pharmacometric aspect of the patient, of the drug, which is patient-dependent, disease-dependent, and drug-dependent. And that makes it a very complex problem when we want to manage medication adherence, because a missed dose, for example, may mean something with one drug for one patient and may mean something totally different for another patient and another drug. So the challenges, I think there are theoretical challenges. We need to work more on the habit. We are defining a habit index. We need to detect changes in behavior, and we need also individualized intervention rather than the quest for the Holy Grail. Most research are trying to find one intervention that applies to everybody. And I think every intervention works, but in specific patients. And we have to identify that perfect match. And finally, practical challenges is the integration to care system, which patients need it when, and is the digital the exclusive solution? My view is that smart packages allow to measure, but not everything has to be digital, because every time there is a digital application, very often it reminds the patient he is sick. Most patients want to swallow the pill and then forget about it. So with that, I thank you. And we do have effective therapies, but to achieve effective disease prevention and management, we will need appropriate adherence to medications. Thank you very much.
Thank you. We will now hear from Dr. Stecher.
Great. Can you see my screen?
Yes, we can.
Great. All right. So I'm going to talk to you about using sensors and wearables for studying maintenance. And this is going to touch on a lot of the topics we've already heard about today, including medication adherence. And I'm going to start by talking about measuring and what kind of measurement signals we can get from wearables, and then talk about how we might use those to test some theories around maintenance. So first, one of the most common types of wearables that I use in my research are activity trackers. So these are Fitbit, Apple Watch. Actigraph is a common research grade device that contains an accelerometer. And these accelerometers measure the time of day, the duration and intensity of physical activity, movement. Some of these devices like the Fitbit and Apple Watch also capture heart rate data. And these are great for measuring physical activity. So the accelerometer, again, lets us measure physical activity in real time. And you can combine that with heart rate to also get precise measures of sedentary behavior and sleep. So again, these are great ways of measuring these three behaviors over time. And with those measures, you can then test theories around maintenance. These devices aren't great for some other behaviors, like we've talked about diet today. But again, for physical activity, sedentary behavior, and sleep, I think we get very accurate longitudinal measures of physical activity, sedentary behavior, and sleep. Another tool that you can use to measure behavior longitudinally is health app data. So this is someone's use and engagement with apps like mindfulness meditation or exercise. This would be if they're using an app like the Planet Fitness app to perform exercise routines. And again, with these data, we can see the time of day, the type of app session, and the duration of use. And you can collect that over long periods of time to measure maintenance and test your intervention or test theories around behavioral patterns that might be indicative of maintenance. I also want to mention you can use apps for behaviors that you might not have thought of, like medication adherence. One example is the Wealth app, where people submit photos of their pills in their hand. So this is a slightly indirect measure. It requires that people engage with the app to submit these photos, but in this example, that behavior is incentivized. So we have good confidence that that's a pretty reliable measure of adherence. You can also use apps to capture things about diet. There's some new apps that use image recognition software to understand what kind of foods are in photos submitted to an app. And again, I like these as a way of measuring behavior over time, and particularly like what time of day and when people are engaging with these tools. A third example that I'll get into a little bit more at the end of this is heart rate variability, which is a relatively new area of research for behavior change and behavior maintenance around heart rate variability, where you can use wearables, again, like the Fitbit and Apple Watch, to collect longitudinal measures of heart rate. And particularly, we use the interbeat interval, so the space between beats. And based on the variation in that space, there are papers showing how you can estimate a person's stress based on their nervous system activity. And even further, you can estimate affect, emotion. And these are all useful signals to help us understand, is somebody maintaining behavior, and maybe what strategies are they using to help them maintain behavior. So this is the brief overview of the types of things we can capture longitudinally. And the question then is, what do we do with these to understand maintenance? So particularly, what behavioral patterns might be predictive of maintenance? And I want to quickly touch on some theory that I've already heard today from our previous speaker and some of the earlier presenters. One of the sort of predominant theories around habits is that often habits are reflexively triggered by cues. These are either cues in the environment, physiological sensations, or these could be preceding behaviors in like a morning routine. And these type of reflexive habits are shown to underlie many long-term behaviors. And so this is a reason why we might want to detect habits when studying maintenance, or understand how to form habits in order to promote maintenance. And a key part of this is that many of these reflexive habits are performed around in the same location and around the same time of day. So there is some value in trying to measure temporal consistency as a way to detect habits and understand if someone's likely to maintain their behavior. And this is where I'm going to jump into some research that I've been doing using activity trackers and looking at the patterns of behavior over time to try to understand whether these type of temporally consistent patterns are predictive of maintenance, or if maybe there's other mechanisms that are determining maintenance in different settings. Another theory that I want to introduce here, and I'll talk about at the end, related to emotion, is that habits could also be a product of learning about a behavior and the likely reward from engaging in that behavior, and particularly the likely emotional reward. And so you can imagine a habit then being something that I engage in and I maintain over time because I expect to feel good after. And this is a harder behavior, or this is a harder theory to test because this requires understanding how people are emotionally relating to a behavior. But I'm going to suggest that one avenue for future research is to use heart rate variability to study expected emotional reward. Okay, so some quick examples of what I'm talking about. Here, I'm going to show you some data from a study that was actually referenced in the last talk around medication adherence. And what you're seeing are two different participants of this study. On the left is someone, they're both patients taking twice daily doses of antiretroviral therapy for HIV. And you're seeing on the y-axis the time of day of their pill bottle openings. And on the x-axis is time. It's a day. And we ran a 20-month intervention with a 6-month follow-up. And what this is showing you is the consistency and variations in consistency around the time of day of their pill taking. While the participant on the left had a high mean adherence, similar to the person on the right, the person on the left had much more variability in their timing. And you can see that during the follow-up, when we're not providing the intervention, it looks like adherence fell apart, whereas the participant on the right maintained a high level of consistency in their time of day, and their habit persisted. And so in this setting for medication adherence, it looks like temporal consistency does matter and is a good measure of habit formation. And this has been validated in some other papers that have looked at temporal consistency in medication adherence. But this isn't true for all behaviors. So now I'm going to show you some data from a physical activity intervention that each dot here is a 3-minute bout of physical activity. So the darker areas indicate days when someone was performing multiple 3-minute bouts in a row. And so the participant on the left is someone who looks like they had a fairly consistent evening physical activity routine. That's indicated by that black line. The participant on the right had much more sporadic walking throughout the day. But what's interesting is that both of these participants had fairly good maintenance of their routines at this 2-week follow-up. And so here, it led us to come up with a couple conclusions that temporal consistency seems to be associated with maintaining high levels of physical activity. So if you have a strong exercise routine, then temporal consistency seemed to matter for maintaining that routine. But there's also different strategies that allowed people to maintain different levels of physical activity. So it's not just that we think cued habits are the only way to maintain physical activity. There could be other types of mechanisms or other types of cues that might not be time-based. A last example I just want to show is how you might use app data. And again, we have time stamps on when somebody used a mindfulness meditation app and how long they used that app. There's 2 users. The person, user A, had a very solid meditation routine at around 7 or 8 in the morning, whereas user B seemed to more sporadically use the meditation app. But both of these users maintained their app use for almost 3 or 4 years. The data you can see on the dates on the x-axis of the top figures. And so here, looking at these data, we could see that temporal consistency helps to maintain higher use of this mindfulness meditation app. But that, again, there's other mechanisms that might allow people to maintain meditation use at lower levels. And this helps us think again about what mechanisms might be helping individuals maintain their behavior in these settings. I'm going to jump into this last part around stress and affect, which is fairly new. So this is based off some recent findings. We ran a intervention to try to promote habit formation of this meditation app. And we encourage people to meditate around the same time of day during an 8-week intervention where we actually provided daily prizes. And then we followed their behavior for 8 weeks after that intervention. And what we actually found was that while there was higher levels of meditation over the 8 weeks post-intervention among our intervention group, the bigger effect was that maintenance seemed to occur among the participants who reported experiencing an emotional benefit from meditating. So this was they checked in with their moods before and after meditating, and those that saw an increase or reported an increase were the ones that maintained their meditation most post-intervention. And so this fuels that second theory I mentioned around expected emotional reward and leads to how we might use heart rate variability to further understand how individuals are emotionally experiencing behaviors. And one of the interesting ways you can use wearables to measure this is through heart rate. So there are many devices now on the market that can record heart rate at a sub-second hertz level. So these are the Empatico, Rhythm, Fitbit, and Garmin and Whoop also measure heart rate at that level, but they're less researcher friendly. So it's harder to get access to those data. And what you can do is look at the inner beat interval, which again is the space between your heartbeats. And there's several different ways to mathematically decompose that time series into high and low frequency signals. So one of the ways is the fast Fourier transformation, but there's a couple other ways that are used in the literature to understand
1 minute warning.
In any moment, is my heart rate, is the space between my beats more explained by a longer frequency signal or a high frequency signal? And this helps us disentangle whether it's your parasympathetic nervous system that's governing your heart rate or your sympathetic nervous system. So right now I'm very stressed and my sympathetic nervous system is likely exerting more control on my heart rate. And that's actually going to make the space between my heartbeats very consistent. And so there's papers, I borrowed this from some of the citations you'll see at the bottom here, that show how we can look at in real time, the time series of your interbeat interval and understand whether someone's experiencing high physical stress, high mental stress, or low physical stress, or low mental stress. And what you can do with this signal is then combine it with an accelerometer data to understand how is somebody feeling about running before they engage in running, based on their interbeat intervals prior to running. And you could, again, do this for meditation, for medication, and combine these kind of signals longitudinally to then test theories around, is it really the expected emotional reward that helps promote the maintenance of behavior? And is that something that we should be targeting as a way to promote maintenance? Okay, thank you. That's what I have.
Thank you. And we will finally be hearing from Dr. Spring.
Okay. Can you see my screen?
Yes, we can.
Great. Perfect. Okay. Before there we go. Before I start, I need to make a point of shouting out, pointing at my collaborators who are pivotal in this work, particularly Farzad Shahabi, who is a graduate student in computer science at Northwestern, and his mentor, Nabil Al-Sharafa, and Sam Battaglio, who's a psychology graduate student also in preventive medicine at Northwestern. So I'm going to try to talk about harmonizing across multiple tools and features to predict behavior change and maintenance. So I tend to find, as a behavioral interventionist, there are two problems that I most often find myself trying to solve. The first is how to tell whether a person has stably acquired the healthy behavior that I'm trying to target, so I can begin to taper the treatment in hopes that they'll maintain. The second problem is whether there's a substantial risk that the person won't respond optimally to the treatment I'm planning to offer, so I should select something different. Now, this challenge might be simpler if we weren't trying to treat some very serious, very expensive behavioral risk factors like obesity that will soon be the norm in our country, and if our healthcare finances weren't in such poor shape. If so, we could offer anyone who wants them very expensive treatments like bariatric surgery, or we could give everyone GLP-1 inhibitors, but we can't afford to do that. And if we give them only to the people who can afford them, we worsen disparities. So I think we need to try harder to find a way to give each person the care they need, not less, but also not more. So I'm going to now reference a study that was funded by NHLBI. This was the first Make Better Choices study, and it was a place where we looked to try to see if a behavior is cooked, in other words, sort of stably acquired. The patients in this study had all four of some very prevalent diet and physical activity risk behaviors. They didn't eat enough fruits and vegetables, ate too much saturated fat, didn't get enough moderate vigorous physical activity, and got too much sedentary leisure screen time. We randomized these patients to 4 groups, 12 treatment groups. Each tackled one diet and one activity behavior. They targeted to either increase the healthy behavior or decrease the unhealthy behavior. So usually when we're trying to see if a treatment works, we look for changes in the mean or frequency of the behavior that we're trying to change. This is what Don Hedeker calls location in his location scale models, which I know many of you are using. But there's a lot of additional information that we've typically ignored about the person's within-person change over time, what the model calls scale, or how consistently the person is behaving over time. Changes in scale, behavioral consistency are easy to get now that we've got dense digital data from trackers and wearables. But, they're also obtainable from a lot less exotic data that we all have, daily data, if we would just refrain from aggregating it. And I'm one of the worst offenders here. I have found all kinds of things since I de-aggregated my repeated assessments of behavior. Here's the kind of information that location scale modeling can give us. This is a schematic of one patient who's been treated, has been treated to try to increase moderate vigorous physical activity. That's the open white dots. And the dark dots, the filled in dots, are person wasn't, their MVPA was not targeted. They targeted other behaviors. And what you see in the white circles is that over time, over treatment, initial treatment RX1 and the later treatment RX2 and 3, the location is improving. The average mean amount of moderate vigorous physical activity is increasing. But the other thing that's happening is the person is getting more consistent. Their scale is decreasing. You can see that those dots are all clustered around the average. Whereas the bottom one, where the MVPA is not being targeted, there's not much of a change in mean, and there's certainly no change in scale. When we analyze this, what we see is that when the behavior is targeted, its location changes as we intend. There's an increase for healthy behaviors and a decrease for unhealthy behaviors. That's what you see surrounded by the purple circle. And the other thing you see is that scale changes as appropriately. When you look at the green circle, when you're getting a change in the behavior is becoming less variable. One interesting thing I find is that there's a correlation between the location increase for the healthy behaviors and measures of habit and self-regulation. Both self-efficacy and habit increase as the location of these healthy behaviors improves. And those two measures, which I don't think should be correlated at 0.6, are correlated at 0.6. So let's shift now and try to go to the problem of trying to predict long-term success and maintenance in something like obesity. We've got a few baseline demographic predictors, but not nearly enough to give us anything like a precision medicine ability to choose the best treatment before starting treatment. Once treatment begins, early treatment response is a pretty good predictor. But my question is, can we extract more granular and informative dynamic data like scale from what goes on during that early treatment phase? And here, I'm going to draw on a stepped care obesity trial called SMART that I did with Billy Namshani from University of Michigan. So here you see the basic design. It is a stepped care design. People are randomized at the beginning to have either just digital devices, a self-monitoring app, a Fitbit, and a Wi-Fi scale, or they receive those tech tools plus coaching. We track everybody's daily weight for 2 weeks, and if they haven't lost a pound by 2 weeks, or half a pound a week, we step them up by augmenting their treatment by adding treatment components. The treatment lasts just 3 months, and our goal is to predict who winds up having achieved 5% weight loss by month 6. That is a mix of acquisition and maintenance. I think it's mostly maintenance. Now, we take these measures, both the static and the dynamic ones, from the 2-week sampling, and we submit them to machine learning. We find that a random forest model gives the best fit, and we can use explainability modules, something called SHAP, to tell us what's going on under the hood of the predictive algorithm. In other words, what features is the machine learning model pulling that impact predictive accuracy? So here is the model output. It's pretty cool. So on the left, you see which variables are having the greatest impact on the prediction. And on the right, you can see what those variables are and what direction they're working in. Far and away, the most impactful feature is weight loss at 2 weeks. We knew it all along. There are a couple of baseline characteristics in the top 10, sex and age, but the vast majority in the top 10 are dynamic changes in weight in that first 2 weeks. Things like the maximum, the minimum, the slope, and an especially interesting one that I have circled that we call sparsity adjusted successive weight variability. In other words, this is the weight variability over successive days, but it's adjusted by the amount of missing data. Okay, now here's the model comparison for what we did, our clinical decision rule, and what we can do with machine learning. Our clinical decision rule, considering people were likely on the right track, likely to be successful if they lost a pound over 2 weeks, was terrible. We only picked up 5% of the people that were going to do well. 95% we predicted were going to do terribly. Now, I can only imagine what this would have been like if we had used a pound or 2 pounds as our criteria for saying somebody was on the right track. It would have been even worse, I think. We looked at logistic regression using just weight loss on day 14 and another random forest using just baseline measures. But far and away, the best algorithm comes from the random forest model that's using the full feature set. This picks up 82% of the people that are likely to be successful at 6 months, and it's a pretty darn good fit. So now, it's one thing to test and say we have a good fit to this model that was developed on this data set. So the way we develop it is we stratify the demographics and the outcome, and we pull a sample of 60% of the smart participants to develop the algorithm, then another 20% to test it, or to validate it rather, and we hold out another 20% that we use to test it. And that test result is what I've just reported to you. But what about generalizability? I mean, if we've really got something, one might hope that it would be a little bit more lawful and extend to studies that use different designs and different measures of weight. So that's what we attempted to look at next. And here I'm going to draw on 2 studies. One, an opt-in study that I did with Linda Collins, and another study that I did with stimulus funds. Remember the ARA stimulus funds a while before that. So here is the basic gist of what these designs are about. So the opt-in study, a fairly large study, used 562 people. The engaged study, we only could use the technology group. There were 3 treatment groups, but that was the only one that had daily weights. Both involve a fixed package and a 6-month treatment. The research designs differ. Opt-in is a factorial design. Engaged is an RCT. And the way of measuring weights really differs. Remember that in SMART, they were weighing with Wi-Fi scales. They were weighing at home, and their data, their objective weight data, were being transmitted to us. In opt-in, they were self-weighing at home and manually self-entering their weight into the app. I'm sure less accurate, but that's what they were doing. And in engaged, we were bringing them in to have clinic weights. So talk about measurement variability. I would have expected some real differences. But now look at this. The black lines are the algorithms showing the area under the curve for the random forest algorithms that were developed on those studies. So the black one on the top is developed from the opt-in study, black one on the bottom developed from the engaged study, and the red lines are what the area under curve is for applying the algorithm that was developed from the SMART study. They're just about on top of each other, showing, I think, amazing generalizability. So to conclude, I struggle with two major clinical or applied problems. One is knowing when the treatment is cooked, when the patient has acquired stable behavioral patterns, either as a habit or a self-regulatory capacity, because they sure look rather similar and correlated to me. I also struggle with knowing whether a patient is likely to succeed or maintain their goal in the treatment that I want to give them, because if they're not going to, I would like to offer them something different that's effective and also efficient, not less, not more than needed. Dynamic features, and I think this has been a theme today, that these things like within-person behavioral consistency provide really rich, impactful information to meaningfully address both of these problems. And these data are really not as exotic and hard to get as I would have thought, having just dismantled 12 clinical trials worth of data where I was aggregating daily data to increase reliability. Using this information in machine learning models, sometimes we're afraid we're going to get a black box, some sort of gobbledygook we can't understand, but there are explainability tools like this Shapley approach that explains what features the model is using, and how they're working, which I think can help build trust in the model, because we tend not to like to use something when we don't understand what's going on inside of it. When we use a clinical decision rule, in our case, it was quite conservative. So I would have thought, I thought it was quite conservative, but it missed the vast majority of the people that were going to be successful. We missed 95% of them. By far, the best approach was a machine learning model that included all the static baseline and the dynamic data from that first 2-week period. That was it, and it did great. This predictive algorithm with these explainable features generalized to different trials that involve different treatment duration, that involve fixed versus adaptive designs across directly measured weights, self-entered weights, and clinic measured weights. Talk about harmonizing across tools. So one question I have is whether these early behavioral and biomarker features should become targets of treatment or signs of acquisition or maintenance. I would bet that for the behavioral ones, the internal consistency has a lot, at least in the weight case, has a lot to do with behavioral adherence, because of the missing data. If people don't enter something, they don't do well on that measure. But I also note there is a very interesting biomarker literature on weight variability, which suggests that it's a marker for severe cardiovascular risk. So I just think variability is something we need to be looking at. And I thank you for your attention.
Thank you so much to our panelists in our second panel session of the day. We're going to take a quick break until around 3:05 p.m. Eastern Time. And then when we come back, we will start the moderated panel discussion with our second group of panelists. So please take a break, stretch your legs, and we'll see you back here in about 10 minutes.
Okay, we're gonna come back from that break into the moderated panel discussion. And I'm going to ask our panelists to please turn on your cameras and your microphone. Oh, and Dr. Mason unfortunately had to leave, and he cannot join us for the panel discussion. So he provided his email address for those of you who want to reach out to him with questions. And his email is Tyler Mass, M-A-S, @usc.edu. And maybe if someone can write in the chat, maybe Sydney, you can write in the chat. All right, well, thank you all so much for those wonderful presentations. And I guess we'll kick off with a question that I think came up slightly during the last panel, related to health disparities and social determinants of health. So I think many of you mentioned technology in your presentations, and technology can be somewhat of a double-edged sword, because it enables us to do innovative research like you have all described, but at the same time, it could play a role in widening health gaps and increasing disparities as different groups may not have access to different technological tools. So what are your thoughts on health equity, health disparities in relation to the use of the tools and approaches that you have described?
I have some thought. I just gave a presentation at NCI on this last week, so I have some thoughts top of mind. One is that I think it's important that we not assume we understand what the digital divide is all about, because things have been changing. It used to be the case that, at least in terms of handheld devices, mobile devices, there was a reverse digital divide, which was largely due to the fact that lower income populations didn't have high-speed home internet. So they were smartphone dependent. That was their only way to access the internet. But the other thing, and I think this is reflected in some new models of tequity that I think are really good, is that we have had a tendency to think this is all about the widget. If you just give people the device, they'll be able to benefit from it. But I don't think that's the case. And I think that some of our models of care need to build in personnel to help people navigate the technology. And those are basically my two thoughts.
Any other thoughts from the panel?
I think one point about disparities, and so it's not only about social disparities, but it's also about some people don't want to manage their health using apps. They want to separate. Apps is more, mobile phones more for pleasure, you know. You do Facebook, you do social network. That's what you do on your apps. You do your emails, you connect with people. But not everybody wants to share that he has or she has swallowed the 10 pills in the morning on social networks. They want to do it completely independently from the digital aspect. So that's what I think. This disparity is not only social disparity, it's also that some people don't want to associate apps and mobile phone with taking medications for medication adherence behavior.
Yeah, and I would just throw in that a lot of the research I talked about using some of these tracking devices are less accessible for many populations, and I think it's an important thing to think about when you're looking at studies using these devices about generalizability and how you might use them in different settings. I think as the cost of these technologies are only going to fall, and I also I think as we can continue to demonstrate the value for people, that usership will also go up. Right now, these are tracking devices, and sort of we're leaving consumers on their own to figure out what to do with that information and what they might want to, what kind of strategies they might want to employ for maintenance. And if we can distill that information in a different way, that might bring more value to people, and then you'll see usership go up.
I think there's another interesting aspect to this that has to do, so this concept of tequity is now, we've thought about it in terms of access to the devices. The next level is individual skills to use them. But a third aspect is the sort of sociocultural, sociopolitical surround around them. So if you don't trust your healthcare system, or you don't believe that your data are private, you are not going to want to use those devices. And that, of course, is confounded with minoritized populations. So, that's something I think we also need to consider.
Yeah, I agree. And that actually brings up a good question that was asked by one of our members in the audience and it was mostly directed to Dr. Stecher, but if any of you have thoughts about this too. What about, using Fitbits or Apple Watches or devices like this that have cloud-based data storage? What is, in terms of ethical concerns, do you believe it's ethical to provide participants with these devices?
Goes to the privacy and data security issues.
Yeah. I mean, I wrote a response. I don't know what's visible to the audience, but yeah, I guess in general, these are risks that we're all exposed to in basically everything we're doing online. And I think just by the fact that people are purchasing these devices, this is clearly not a risk that's stopping folks from doing that. And then I would just throw out, like, we go through pretty rigorous IRB reviews, and we try to mitigate these risks when outlining any of the studies. But in general, I mean, I've been involved in discussions around data risks and confidentiality broadly. I think it's important that we have these discussions and really try to quantify those risks to understand if the benefits outweigh the risks. And right now it seems that they do. Even in like some of the more horrific scenarios where I've heard people using data to exonerate them from murders, or maybe to like prove that they were involved in murders, I think those risks still don't seem to outweigh the benefits. But down the line, if we find ourselves in a completely different governmental regime, and then the risks might be different. So yeah, currently they're not too onerous. But
again, I think it's interesting I think it's important not to assume that we know without studying. For example, you might make an assumption that people don't have the internet because they want it and they just can't afford it. Well, that is true for a certain portion of the people that don't have home internet. But for young people, they don't have it because their smartphone does everything that they want. So and something like 70% of people that don't have home broadband cable don't want it. So the data are just full of surprises.
Yeah, I agree. And then we have a quick question kind of building up on this. What about social desirability, cultural sensitivity, and issues like that?
Go for it, Chad.
You're muted.
I was going to say, can you rephrase the question? Is it just how do we factor that in, or what about?
Yeah, again, thinking about all these wearables, all this technology, and specifically with populations that might have issues with cultural desirability and
let me tell you the one that
cultural sensitivity.
There's one that I really worry about now that is I think incredibly important and time sensitive, and it has to do with telehealth. We know that so telehealth became a big deal during the pandemic, and it increased access for a lot of underserved populations that couldn't get to the hospital, working multiple jobs, couldn't get childcare. It was really a hugely helpful thing. Now that the pandemic is over, there is a big move to eliminate telehealth coverage for phone only. I can tell you from the work that we do in our health behavior change programs, it's the underserved populations that want to use phone only. Either they don't know how to use the technology, they don't have broadband, which it's very hard to use on a small iPhone screen, or there are privacy issues, or they're doing it at work or whatever. So I am very concerned that coverage is going to go away, and that's going to really worsen disparities.
Yeah, I guess from the concerns around wearing the devices and is that sort of what you're talking about with social desirability or maybe like stigma?
I believe so. And this was a question from the audience.
If I can also, one of my concern, where we are operating primarily, it's clinical trials. So we give the device and we give the packages to everybody. When it comes to medical practice, I think my concern is to take care of the other half. I call them the other half, because when you come with technologies, the first half are all the good ones who want to show how good they are, how good they are taking their medication, how good they are losing weight, and so on. My wife is a teacher, and when she organizes a meeting for students, she gets all the parents of the good students to listen how good are the kids, she never gets the parents of the bad kids through because they don't want to hear that. And we face exactly the same. It's the cost of the devices and so, but also the cost of healthcare providers, because once you start to integrate that in care, healthcare providers will get those data and spend a lot of time to see how good half of the population is. And then how do we tackle the other half? That's really the issue, especially in medication adherence, but I'm sure it's the same for other behaviors. Because that's
And this is
can make a change, a difference.
right. And this is actually a good transition to another question that I had is we've been discussing using these tools and methods for monitoring, assessing mainly in our research. But do we see these as potential interventions on their own, right? So if we're wearing a device or that's in a way prompting us to engage in the behavior, and does this matter? Do we see it as introducing bias? Do we see it as even desirable? Maybe, as I think maybe Dr. Riens, you alluded in your presentation. How do we translate this to real world? Any thoughts about this?
Yeah, and again, I think the issue is that I'm talking again for medication adherence, but when you have a patient with a chronic disease for 30 years, I don't think he should use an app or a device for 30 years. Most of the habit can be based on event-based breakfast and so on. However, there are some key patients at key time points who could highly benefit from electronic monitoring. So when you initiate a treatment where you know that you have a very narrow therapeutic window, building that habit is key. That's one aspect. The other one is when a treatment fails today, we increase dose, we add a treatment, we change treatment. That's a key time point when you can also start electronic monitoring to build that in the treatment decision. And so there are different aspects when you can do it for selected patients at selected time points. That will be the most beneficial in my view.
Yeah, I like that description of the wearables as almost like training wheels that you can use them in interventions to detect or suggest ways of establishing a habit. And then over time, you no longer need those supports. I mean, the goal wouldn't be that somebody wears these devices forever, but that if it's somebody trying to build a medication habit around breakfast, we can see, are you taking medication around that time? Physical activity, are you doing this in the morning, or whatever your pre-committed cues and routines might be? We can detect that using wearables, and then over time know that habit is likely to establish.
I actually wonder, I guess I'm thinking of the case of physical activity. Think of the number of people that wear their Fitbits. Maybe they use them initially to acquire a habit, but it's become something that's built into their routine now. They like the feedback. It's a reminder of, that every day this is something they need to think about. What's so bad about that?
No. If we think an ideal world is having everybody monitored for everything forever, but I think that would add a lot of burden. It's not the vision I have, at least. So really, I think we need to have a selective use of it to support daily habits in general, and then try to remove them. And if patients want to keep it, perfect, they can keep it. That's not an issue. But most patients will probably prefer, especially for medication adherence, most people want to swallow the pill in the morning and forget about pills and disease for the whole day, and not be reminded and games and points about their medications. It just reminds them they are sick. Most people want to forget about it.
Yeah, I mean, I'll throw out a minor plug for this new idea around the heart rate variability measure, because I think this is actually an interesting feedback and kind of way of self-tracking and monitoring that can provide new information to the individual. It's, oftentimes we have a ability to access our emotions and understand what we're feeling. But these measures of stress can help understand, okay, this physical activity habit might not be forming because you don't like physical activity. And like the way you're just trying to do this is inducing a lot of stress and anxiety. And so this gives you a new target for an intervention that might be, let's find something that's not as stress inducing, or let's find something that might be less emotionally triggering, so that you're more likely to engage in the behavior and then over time form this habit. And that might be a new signal that people can factor into the way they design their routines and think about engaging in health habits.
So I'm gonna try to get to some of the questions from the chat, and one question is, do you see the advances in our technology and analysis moving us from a reactive approach to observed non-adherence to a more proactive approach where we could better intervene with those predicted to be at risk for non-adherence?
So for non-adherence, I think for sure, it's very difficult, in my view, to predict non-adherence from baseline because there are 700 reasons why patients are non-adherent. So prediction is extremely, we can find associations, but prediction is very difficult. But by monitoring it and measuring it, you can have predictive algorithms. And I think this is very similar to what Dr. Springs showed about weight loss. It's when the dynamic factors are the ones predictive. And it's the same for medication adherence. The dynamics, the habit, the change in behavior, and so all that is highly predictive. So absolutely, yes, that has to be built in feedback and interventions in the future.
Yeah,
and I think that's the concept. It's the concept behind just-in-time adaptive interventions as well, which I think we are getting close to being able to do, although they're still not easy.
Yeah, I found your research very interesting on how you used the predictive algorithms. Let me get to another question in the chat. What I'm wondering is if we seem to keep getting caught in a circular pattern where we want to define and measure behavior maintenance by the factors that predicted. One, should we call something maintenance if it is by things that theory suggests should predict maintenance? Or two, should we call something maintenance based on set criteria and then examine what things predicted to build better theories?
I think these go to the core of the definitional issues. If you want sort of public health fixed standards, that's one thing. If you want iterative, based on how much somebody has improved, or you want something more personalized based on what they're aiming for, it could be anything.
I think it was the first half of this workshop was interesting because it is really domain specific. I mean, for smoking, the success of their ability to define maintenance is partly because the behavior is so clear. It's just don't smoke. Whereas, medication adherence could still look a little different. You don't need necessarily 100% to maintain the success of medication. For physical activity, what that means is a very, more debatable subject. And so I think right now it feels like data-driven solutions and trying to understand what patterns of these behaviors are shown to be, maintained over time, performed over time, seems like a kind of a fruitful avenue for trying to quantify or better measure maintenance. And then to what Bonnie said, sort of like an iterative process. We now have the ability to measure these things. We have the ability to measure the physiological benefits and the outcomes. And so we just kind of need to keep generating data to understand how the behavioral performance relates to the outcomes that we're looking for in order to understand what the maintenance level is.
I'm actually intrigued, Bernard. I would have thought that for some medications, you would have said they're analogous to smoking. You got to have perfect adherence or you're going to lose the benefit.
Yes. With medication adherence, there is a major, in my view, regulatory issue, because there are a lot of treatments. Let's take examples that are once daily. All the patient's information says every 24 hours. Once daily, take it as consistently as possible every 24 hours. And some you can miss doses and some you cannot. And this is not known. This is not an official communication to physicians, to patients. But you know that if you miss a statin, it's not critical. If you miss an anticoagulant, it's critical. But this is the same for patients' information. It's exactly the same.
Interesting.
And that's a huge concern in my view. And the FDA is just launching a patient's information document that is new. And I think we should tell the patients how forgiving are those treatments.
The one place it does seem to be emphasized consistently that you have to take it all is with antibiotics. That's the only place I've ever heard it really emphasized.
And you talked about this a little bit, Dr. Stecher, but I was wondering if others have thoughts or you have further thoughts about how we can use these innovative tools and methodologies that you've described to help us to reach consensus regarding the definitions of maintenance for the different behaviors, which was discussed in the previous panel.
Yeah, I think it's tough, especially across behaviors, because maintenance will look different. I like the idea or the theories around my sort of expected emotional benefit of a behavior, because I think about physical activity for me isn't often cued, but I do it fairly regularly, and it's one that I've formed a positive expectation. I know that, like, even though this is going to suck, I'll feel better at the end, and that's maintained this behavior for a very long time. And I think the closer we can get to understanding both the frequency, duration of performing the behavior, but also the way that the individual is emotionally relating to that behavior before, during, and after, I think that can move us closer to a model of maintenance that works across behaviors, where we really think about, is this a behavior that's becoming something that's like ingrained in the person's identity and the way that they, emotionally expect to benefit from it.
So Chad, what would you do if I want to be physically active, but my ideal and the level that makes me feel good is 15 minutes of moderate, vigorous physical activity a day. And that has the affective benefit, but it's not getting me near the public health guideline. Would that be an acceptable outcome, an acceptable level of maintenance? Because I think that's the big divide, is just how idiographic versus sort of nomothetic are we going to make these criteria?
Right. I mean, that's a great point. That's a great example, because that is, to your point, that's something that's likely to maintain. It's a behavior that I expect to get a good reward from. Mm-hmm. The question then is, as health researchers, is that going to give you the health benefit? And if it's not, then I would say, it's not something we want to, or we want to find a way to either add another behavior or lengthen that bout in order to help you achieve the health benefit. That, at the end of the day, we're all motivated by the health outcomes. And so it's, how do we improve health outcomes? And we know it's behavior change that's needed. And so that's why we're having these discussions about maintenance. But at the end, it's really about moving the needle on the health side.
Yeah. Yeah, and as
there was
Rita and Stephanie were saying, it would be like a partway goal in treatment. And I think that's what you're talking about. There's the tools and the ways of thinking that we use to shape somebody's behavior towards where we're trying to get them. And there's the question of, are you there and are you maintaining? And the latter is more rigid, I think.
And I think maintenance and adherence across those behaviors are different in terms of definition, but also in terms of required interventions and measurements and definitions. It's different. In Europe, there has been a push by the European authorities to put everything in the same bag, adherence to all behaviors. And I think this type of meetings is very useful because we can learn from each other and from one field to the other. But at the end, it needs to be tackled, in my view, separately.
Yeah, I mean, we've done some work on medication adherence with HIV, and I'm not the expert. Jessica Haber is, and she can definitely correct me when I'm wrong. But I know that like the threshold isn't exactly 100%. There's for various medication, you can be around 90 or even 85. And so in those settings, maintenance doesn't have to be a very rigid routine. It could be something where you build a habit around afternoon walks. And those might not happen every day, but that's okay, because as long as they happen around 90% of the days. And so, to your point, that maintenance is going to look different for different behaviors based on the clinical outcome that we want to change. And so I think discussions like these are great. I would, in the future, having some clinicians involved, I think that's sort of a gap that all of these domains need to tackle, which is what is the behavioral threshold that's necessary for achieving the clinical outcomes that we're trying to improve.
Yeah, and even I hate to use those numbers, 90%. This means missing 10% of the doses. This means 36 doses in a year if it's one pill a day for 1 year. If you miss them consecutively, it's the same than to say end of November, you are done for the year, you have enough, So we have to, the behavior is not only the percentage, it's the behavior really.
And the dynamics.
Dynamics, exactly.
Well, I'm going to move on to another question in the Q&A, and this might spark some innovation. So someone says the HRV applications are very interesting and based off a new tech biomarker, HRV. Are there other specific markers or biomarkers for an aspect of maintenance for which you wish technology existed, but there's nothing yet that can measure it in such an easy way?
Very interesting.
I mean, a cheat would be if we could measure the health outcome, right? If we want to directly see how physical activity is improving metabolic health. Someone's like postprandial glucose response, so the way that their body reacts to meals, if we could see that in real time or like over the days based on their level of physical activity, that could help us better make this connection between performing and maintaining physical activity, but the health outcome that we really want to see improved.
Any other thoughts from there?
Looking between the behavior and the outcome is that there is not always a one-to-one link, because there are many other factors influencing the outcome. And very often we think, look, if I can show that better adherence leads to reduced blood pressure, people will be motivated. They will see the adherence, the blood pressure. Yes, but if the blood pressure is not going down, what's happening?
Or like in diabetes, the same thing. And you tend to not believe the patient. You think they're not behaving, and that's why their hemoglobin A1C is not going down, which is not helpful.
Yeah, exactly. And there are a lot of, adherence is not the only source of, it's a major source. It's not the only source of variability. And so interpreting those data are extremely complex.
Yeah, another one I haven't seen is sort of social interaction around maintenance. I know, various interventions have used social support, peers. You could think about like a way of measuring who's around when you're performing the behavior, or who are you doing it with, as a way to understand like how is this habit being established? Is it being done as sort of like a collaborative thing with your partner or someone in your household? That could be an interesting measure that I haven't seen people. I think it's a little bit hard with devices right now. The GPS on some of these trackers isn't accurate enough to really know what room in the house you're in. It can tell you that you're in a house, but it can't tell you exactly where you are. So that would be an interesting one to be able to have access to.
I think we're getting to the time of wrapping up. So thank you all so much again for your wonderful presentations, for this great discussion. I believe now we're gonna bring other panelists, and I'm gonna pass on the baton to is it Sydney or Deborah?
I think it's to me at this point, everybody.
Okay, great. Well, thank you so much.
So I want to thank all of you thus far today for your fantastic presentations. It's been very informative and very complex. And as I said very early this morning, it's been almost like a fire hose of information. There's just so much here. I want to welcome all of you, our panelists, our moderators, co-chairs, co-leads. The purpose of this next discussion is to gather and highlight key findings from today's presentations and discussions. Please share one or two important learnings or concepts that you have identified as important in informing the science of behavior maintenance, measurement, monitoring, and tools going forward. Just to throw it out there as examples of today's presentations, the need to measure temporality, intra-individual behavioral consistency, and longitudinal behavior patterns to predict development of adherence patterns and maintenance were mentioned. Another novel, to me at least, area that came up was the constructs of preventive risk adherence and ancillary risk reduction. How are they the same or different? They came from two different silos, if you will, of studies. Throw your ideas against the wall. Let's see what sticks as generalizable and what has been termed idiographic. To remind attendees, please do the same. Share your aha moments and ideas. We will use all this information to frame Friday's meeting, planning of the fourth and final convening, and aggregate key findings for today's meeting. Summary ready, set, go. I don't know how to do that though. People raise their hands. What do they do? Just unmute themselves. I'm going to mute myself.
Yeah, I think that makes sense. I'm just going to ask who's my, can we are we at is 9 the cap of what can be spotlighted?
Nine?
I just posed that question.
They're not 9. There's just, at least on my screen, I assume, and everybody's 9 of us are spotlighted in the center of the screen, and then there's an array of us at the top. And so in any case, okay, so that's but would somebody like to here we go. We've just added at least.
Now I understand what you meant, Alex.
So in any case, any sort of aha moments that people want to put on the table? I have in response to Deborah's.
I thought the temporal patterning, the consistency, that's the thing I came in with, and I'm taking it away.
Yeah, and I think, related to that is, kind of this a theme kind of all throughout here, which is that even though we have today this meeting, which is focused on monitoring and measurement, and then on Friday, we'll talk more expressly about intervention. I think a theme here is just how closely braided these two things are, and how much our measurement and monitoring can inform and tailor and strengthen the delivery of interventions, their timing, their content, and then also to whom we prioritize those interventions. And so for me, it's very exciting to kind of see that interplay. Assessment is intervention, in multiple meanings of the term, perhaps. But stellar talks today, and much appreciated.
Genevieve?
Yeah, so what really struck me was a point that came up in the panel for the first session was that there is quite a difference between thinking about maintenance from an epidemiological perspective or for the purpose of surveillance or measuring it, and then treating or intervention, and that really struck me. And then the second thing is that we really I put it in the chat, but this idea that, and this is something that I've struggled with, my team has struggled with, is that when we're trying to define and measure something, are we defining it by the things that predict it? And when I say predicted, I mean, are there different constructs, right? So when we're thinking about a predictive model, we have predictors and outcomes. And so we're talking about the outcome here, but the predictors are so closely embedded. For example, something like the context or contextual consistency could be part of the definition of maintenance. They're doing it in the same place every time. So we're going to define it as maintenance because they're doing the same place every time. But in some ways, if the place is cueing it, or the place is somehow a separate construct that's predicting it, you could say the same thing for affective or emotional rewards. If we're using emotional rewards as a way to, if it's emotionally rewarding, then it's habitual as a way to define it, or are we saying if it's emotionally rewarding, it's more likely to be habitual, right? It predicts it. So that's just something that is tricky. So we've all been struggling with this, but I just think that's a point that that's important to think about.
Other observations?
What about my question about those constructs that were thrown out? Predictive risk adherence or risk prediction adherence versus secondary reward mitigation or enhancement. Are those things the same? Do they come from the same place? Should they be considered, to your point, Genevieve, in the definition of maintenance? And is that contextual? Is it dependent upon fill in the blank? So, for example, in our last panel, people were talking about how adherence doesn't always predict metabolic changes, right? But it may predict how somebody feels about themselves, right? They're doing better. Susan Joukowsky always likes to talk about identity, illness identity, and change in illness identity. And, that's part of the process of maintenance. Well, should it be in the definition or not? I'm echoing you, I suspect.
This is just a knee-jerk reaction, but I sort of lean towards saying, okay, the outcome we think about in terms of epidemiological public health, objective fixed definitions. These other things we think about as techniques, behavior change techniques, ways of getting somebody to the outcome that we think is advantageous. That's just my knee-jerk.
I think it's a good point. I'm sort of going to echo what Genevieve said, because I think there feels like there's two different ways to measure this. And I don't know there might just have to be two measures. It's the clinical goal that maintenance is then a strategy for, but maintenance you might not be able to achieve maintenance in settings unless you're doing behavior in the same context at a frequency that might even surpass the clinical benefit, but that's supportive of maintenance itself. And so there seems to be like two targets, one being what is the psychological mechanism that allows you to maintain the behavior that then produces this health benefit. And those don't have to be exactly the same. And you might end up having to do more medication adherence than what's clinically necessary, but because more medication adherence allows you to form a really stable habit that becomes incredibly reflexive to your breakfast, we would encourage you to, take it daily. And so I think these become then two different outcomes.
thing that I worry about is the question of what should we aspire to when it comes to maintenance? Is it enough to have something, a behavior that can be reliably contextually cued as long as you're in that context? What happens if you travel or if you get sick and the context changes? Should it be part of what we want from maintenance that you've got both the sort of surface level cueing and you've got some self-regulatory capacity that's your backup system?
Yeah, I mean, I would agree with you, Bonnie, that we would want both from a clinical perspective. It's just whether when we're measuring maintenance, do we measure, and when we define maintenance, do we have to measure both? And so one thing we can think about, if we were to go to like a classic trans-theoretical model, and we have action and maintenance, and if you think about it in the realm of physical activity, the only difference between action and maintenance is really how long you've been doing it, right? And a classic trans-theoretical model way, so that someone in action is doing the same amount of behavior every day as someone in maintenance, right? So when do they cross the threshold into maintenance, right? Is it after a certain it's typically after a certain duration, but we don't know what that duration is, right? And it's just been 6 months or 3. So if we look at some other indicator of whether they cross that threshold, so on the surface, we see they're doing 150 minutes of MBPA. But under the surface, one person is doing a ton of deliberative kind of self-regulatory, high effort decision-making processes. And for the other person, it's become much more automated, right? But on the surface, it looks exactly the same. They've been doing it for the same amount of time. They've been doing the same amount of behavior. So if we don't look under the surface, we would say, well, the intervention succeeded. Both are maintaining, but one would be very vulnerable to lapsing, and one would maybe be more robust to lapsing. So that's just kind of an example of how tricky this can be.
But is this not a point that when we will, if we want to have this maintenance and have powerful interventions, they probably will need to be individualized. And the only way to individualize is to measure. And that's why measure, manage is the key. Because I think more and more in medication adherence, every intervention works. Whatever, it works in a subset of the population, and sometimes a very small subset, but it works, And the question is, can we define a set of intervention, and it should not be too many to be applicable in real life, but can we have a handful of interventions that we can select the right people for the right intervention and succeed in 80% of the people? Because one intervention will only succeed in 30% of the people or 20% of the people. But if we can really individualize based on measure, probably we can reach 80%.
I'd be very interested to get your reaction to what you're hearing, Anne. Anne is our
So guys, I'm a clinician, right? And so you're teaching me all sorts of things that I didn't know and find fascinating. But I want to point out that as a clinician who only does diabetes, all I do is monitor people, right? And all I care about is long-term behavior change because I want all these people to have healthy diabetes-related habits for the rest of their lives. And by monitoring, I can actually do the opposite. I can say, you must have been very stressed this last week, Monday through Friday, because I can see their sugars go up and then I can see them come back down. Or, I know when they travel, I have to figure things out. So there's this behavior maintenance, as you're talking about, that underlies the whole situation. But then there are these changes that are so amazingly reflected in their blood sugars. But my bigger problem is working with my under-resourced patients because the social determinants of health that they face, the problems, the food insecurity. I think one of the best things my clinic does where we do remote monitoring is make sure people figure out which food bank to go to. I mean, we're really involved in trying to help them survive in their world and on top of that do what is difficult, which is long-term behavior maintenance for diabetes that requires insulin. And that's really hard to do. And I think we're much less successful. On the other hand, as we measure success, I have 200 people in East LA on CGM who love it. Our dropout rate from our studies is like 1 person. They love it. Why do they love it? They love it because they have us. They have my study coordinators. They have a human being who makes sure that they know what they're doing, who encourages them. And one of you, and I think it was perfect, says that all of the devices need to come with a support person to help them learn them, to support them, to motivate them. And if I had a support person for all my patients, and it can't be me. I mean, frankly, I love them all, but I can't be the one to support a couple thousand people, but my staff does. And so I think taking all these elements, and so what we're going to talk about on Friday, is really how do we weave everything you all are saying that I think we all agree with into really changing a population or changing, people with multiple issues. And obviously for diabetes, it's weight, it's lifestyle, it's all sorts of medication adherence. And by the way, my one only other thought is on my west side, where I have higher SES kind of patients, and they're more health literate, they'll come in and tell me what percentage adherent they were. They'll say this, in the last 3 months, I was 80% adherent. And even if they say they're 60% adherent and their A1C is still at target and their LDL is still at target, maybe they don't need to take it so much because whatever they're doing is working. So I'm not even ever a slave to a number. I'm a slave to what's working for the patient and looking at those outcomes sort of more generally. But those are my thoughts. But I've loved listening to you all. I mean, it gives me hope in the world. You guys are so smart. It's wonderful.
I'd like to turn back to the comment that the theme that Genevieve was raising, and my instinct here is that there is value in actually disaggregating whatever we settle on in a behavioral domain, the behavioral definition of maintenance, from the things that we think are key determinants of successful maintenance, or things that are that are sort of inhibit the performance of maintenance. And so you know what I mean. So for example, there have been a couple of different instances that have been suggested. So it may be, I think, Chad suggested that sort of maybe a critical role for some form of affective expectancy or expected reward of some type. And I think it's worth disaggregating the idea that we might be tracking people and their behavioral performance, and we can decide whether we want that to be a idiographic criterion or a nomothetic criterion. I mean, in some domains it's set, right? So in smoking, we have an idea what it is. In physical activity, I think we generally have no idea what that behavioral performance could be. But, and that should be distinct from the things that help support the performance of that pattern of behavior. And both may be really important to track, right? So in other words, it's not so much that if you disaggregate them that they are one is less important than the other, but they seem to be distinct. And they might actually serve different functions, right? So one question could be, are these things to what extent are some of these constructs antecedents to successful maintenance? Or to what extent are they just byproducts, things that are produced because you're in maintenance, right? So in other words, and it may well be that what we find is that we want to monitor them both because, and I think a number of people suggested this, I think you were suggesting this a moment ago, Genevieve, that shifts in those determinants might be like early warning signs, right? And I apologize, because a couple of people have talked about this kind of notion, right? So that, the behavior might be moving, but we might begin to see that Alex is just not as, pleased with his physical activity as he used to be, or as interested in it. Or, he keeps doing it, but to use some of the sort of examples, at least I have in my mind, that Chad was showing, but my God, he's starting to get in, when he's doing it, is starting to look unstable, right? And so there are things that we may be able to identify as things that say, I wonder if if in a sense, Alex, as the example, is at risk of of beginning to slip or deviate from maintenance. I think if we hide those constructs into the definition of maintenance, I guess I'm sort of with what Genevieve had said earlier in the chat, and which had been read, which was, I think we get into a really complicated sort of circular definition that I don't know how to get out of. So That would be my perspective from today. Now, what that looks like, whether all the, I guess I'll pause and just say, you know, maybe there's a compelling argument to say that the need to dissociate those things differs in different behavioral domains. I don't necessarily say that there's one sort of one way out here for each of those behavioral domains. But.
Maureen, you indicated there were some questions in the chat. Was it the chat or the Q&A that you thought were worth discussion?
Well, I think I've really appreciated hearing everybody's takeaways, and clearly we're all wrestling with the complexity of these topics. I do appreciate everything that people have put in the Q&A, you know, I saw a question related to kind of the role of caregivers in behavior maintenance, which also kind of made me think about overlaying a developmental context into thinking about behavior maintenance and how these may change over time. In my own world, I tend to do more pediatric focused research, and obviously there's complexity when you're looking at environmental I guess, contributors to behavior maintenance, and even thinking about measurement in a pediatric group. And wasn't sure if there were any thoughts about developmental aspects, particularly for measurement of behavior maintenance, that we can take away from some of the presentations today.
How many people work in the pediatric space or the family space besides Maureen? It didn't occur to me to even go there. Raise your hand. Bernard?
We do have studies in pediatric, yeah.
Yeah, Genevieve, Maureen. Rest of you guys are all in the adult world? Interesting.
Yeah, I think it's sorry.
I think those tracks sometimes bifurcate, Maureen.
Yeah, it's interesting because I think the more that I get interested in maintenance and habit, I tend to move away from the pediatric space. And it's interesting to bring that up because I think that, I mean, obviously, you know, children can demonstrate behaviors that are maintained. We see, you know, children put their seatbelt on, they can brush their teeth, you know, but the question about, you know, obviously the substance abuse piece doesn't, I mean, it certainly applies to at some level adolescents, but maybe not, you know, younger school age children as much. So I think it is interesting. And but I do think that that's a completely unknown, right? And if we're trying to establish healthy habits early, healthy eating, healthy physical activity, we can't shy away from it. I think we just see the role that parents and caregivers is pretty large in that area. Also, and in that case, the role of rewarded behaviors is pretty critical, maybe even more critical for adults, you know, that the behavior is somehow enjoyable or rewarded in some internal external fashion. That could be pretty important for creating habits. But I agree, it's even we think we don't know much about some of these habits in adults, and I think we even know less in children.
Yeah, I mean, I guess I'll just echo that and say, like, largely I haven't seen a lot of this stuff done, or these kind of techniques and this type of measurement done in pediatric populations. I think it would be very interesting because I think it's an important time of life to form habits, but also you could imagine arguments for why it would be easier or even harder to build habits among that population. I think that would be an interesting way to test these theories by comparing the success of interventions that were run among adult populations among a pediatric population. Understanding why those results might differ would be really helpful to help, you know, answer some of the questions we've brought up.
So it sounds like this is a real research gap.
And you need to understand the behavior of the kids, the behavior of the parents. And I remember one study we did in growth hormone. The kid was perfectly adherent 1 week and not the other week because the mother believed in the medication and the father not, and they were separated. And so you could have a perfect behavior 1 week and the completely opposite the other week. So it's a difficult, very difficult to research population. More complex.
Maureen, did you have other questions, or would you like to wrap us up and segue us to Friday's meeting?
I mean, I can certainly defer to my colleagues and co-chairs, but I think we all recognize that sustained attention on Zoom can be challenging sometimes, and that we greatly appreciate all of the contributions thus far today. If anyone has any final thoughts that they would like to offer related to measurement of behavior maintenance, or key takeaways, or thinking about measurement in context of some of the disparities that were discussed earlier, certainly would welcome them. If not, happy to give everyone back a little bit of time and move us to wrapping up.
Maureen,
Yes.
I just was going to just add one comment more, just more a call, so to speak, than lack of anything, is that I think integrated conversation of some of the issues that came up this morning with a discussion of the tools this afternoon, and to think about perhaps if there are opportunities for alignment, right? So that, you know, as to what extent are we optimizing what some of these tools could actually tell us to help sort of answer some of the definitional questions that were raised about maintenance. I think there are definitely some places where that is happening. And some of that is very much going to be data driven, could be very much sort of data driven, but I wonder whether there are, whether the tools that, Bonnie and Bernard and Tyler and Chad talked to us about, actually could also be used to sort of more specifically to address some of the definitional issues. And I think, that isn't obviously something, I don't have a specific example at the moment, and that isn't something to answer today, but I think it's just struck me, given that we had this rare moment where we had these different communities of people at the same table. And I think in terms of sort of future opportunities, I think that would be something to put on the list.
I was just going to piggyback on that, because I think that's a great point. And I've actually found myself bothering folks like Alex and Genevieve personally to see if I could sort of, I know they must be running interventions and the power of these wearables. And so the idea of stacking together some of the devices that I talked about and that Bernard talked about, and so we get multiple measures going in the same study, I think this would be a really powerful way to sort of tease apart some of the questions. And so synchronizing as a group, these multiple devices would be really powerful.
Steph has a question or a comment.
Yeah. Somebody needs to unmute her.
You're muted.
I think she needs someone to unmute her. Yes, she does.
Thank you. Thanks, Bonnie. I did want to comment because I do think that in a lot of my own work, I've been really excited about the power of ecological momentary assessment and wearable devices to help untangle that like heterogeneity that Genevieve and I were talking about in terms of what behaviors constitute a dietary lapse, or what behaviors constitute a physical activity lapse. So we've been using and combining EMA and wearable devices to try to get at this more granular level of eating behavior that sometimes people can't really report to us on all the time. So for example, we're using wearables that detect and characterize eating to say like, oh, wow, the rate of someone's eating is actually what's contributing to their lapsing, as opposed to more like the amount of bites that they're taking, for example. Or lapses are more just like actually a combination of the number of bites you're taking and the rate that you're eating. So I sort of wanted to piggyback on that to say that those things are in process in some of our labs and actually really fruitful. So the call to have more of that type of research, I think could be really eye-opening across fields of different types of maintenance behaviors.
Genevieve?
Yeah, just to piggyback on that, Steph. I completely agree about the power of EMA, and but it doesn't always solve everything. So one thing we've really struggled with is we've been trying to figure out how to use EMA to capture dual processes that underlie behavior maintenance. So automatic and deliberative, and there's not much out there in terms of existing self-report measures to try to adapt to EMA other than the self-report habit index. And so, the problem is when you start to ask people, and we have this item and Alex knows about it too, it's just, we're trying to figure out to the extent to which someone is deliberating about doing a behavior or kind of not really thinking about it. And the second you ask them, so we say, kind of, are you thinking about upcoming behavior? And then they say, well, I'm trying to decide if I should do it, or I haven't really thought about it. Well, you just ask them. So now they thought about it, so trying to get whether something's automatic, and then you're asking them, this is where we've struggled, so we're trying to capture these underlying psychosocial processes to see what is supporting or what is underlying the behavior. And EMA is really cool, and it's helpful, but we're struggling in that case too. So
I think that's such a good point. And it also reminded me of like another thing that I thought was a big takeaway from this, which is there was some talk about, social and structural determinants of health, but I think it's really, really challenging when you're zooming in on behavior to then also zoom out. So like, that's what I struggle with EMA a lot, is trying to like get at these very like moment to moment psychosocial processes, but also trying to make sure that I'm also in all of my studies and in my models and things like that, accounting for like these vast structural and social determinants as well. I think as a criticism of my own research, I haven't been able to do that as well. And it's something that I have my eye on moving forward, but I think it's just like a tension that we all have to be careful of when we're zooming in particular. I think it's really easy to forget that as well. So definitely like using these tools is great and we should be doing it. And also there are lots of things that we need to consider as we apply them. So thanks for making me think of that as well, Genevieve.
So I was being snarky and I sent Genevieve a comment in the chat that says, my favorite comment regarding stages of change theory is, quote, pre-contemplation is an oxymoron.
Are you contemplating it? Well, now you just said it. So you've ruined it. You can't be in pre-contemplation anymore.
That's the point. Back to Maureen.
Okay, great. Well, thank you everyone for sharing those final thoughts. I am going to go ahead and try to close down this meeting. I really want to offer a big thank you to all of our presenters and moderators and all of our participants today. Also, a thank you to OBSSR and the NIH-wide Adherence Network for supporting this workshop series. And of course, to all of the co-chairs who really put together an excellent slate of presenters and discussions. I was incredibly impressed with the depth of discussion that we had today. And this is obviously a rapidly advancing area. And I think that we had some great conversations really thinking about, precision in language, how we're operationalizing behavior maintenance, harnessing innovative technologies to really measure maintenance over time. And certainly the challenges of disentangling measurement of maintenance and intervention. And so that leads us, I think, very nicely into thinking about our next workshop, which is going to be held this Friday. So as a reminder, as you may have seen in the introduction, this is the second workshop in a series of 4 planned workshops that's focused on advancing the science of behavior maintenance. This workshop series really builds on a long-standing interest to conceptualize, measure and monitor and promote maintenance of health behaviors, hopefully with ultimately implications for implementation into clinical practice. We are going to be working to produce a distillation of this meeting series, and hopefully we'll be able to disseminate this information through multiple channels. As we have discussed, I think a few times in the chat today, we aim to be able to share presenter slides at a later date if presenters have given us permission to share their slides, but there will not be a recording available from today's session. But I really would encourage you to really think about today's presentations and discussions going into our Friday workshop on interventions. You see some information up on the screen. Registration is still open. So for people who have only registered for today's session on measurement, you are certainly encouraged, if you are interested in continuing this conversation, to go back to our meeting series website and register for Friday's workshop on interventions. Just as a preview, this agenda is also available online, but we really hope to build on these conversations to focus on interventions for behavior maintenance. The full agenda with the speaker bios is available on the website, but we will hear really exciting presentations on example interventions that demonstrate efficacy for promoting behavior maintenance, particularly thinking broadly, as we tried to do today, across behaviors and disease contexts. And we'll also have a really robust panel discussion thinking about mechanisms, methods, and approaches to advance intervention science and behavior maintenance. So some of the gaps we've identified today in measurement, hope to also identify some really critical future directions for interventions for behavior maintenance. So I think we are giving everyone back a little bit of time, but do want to thank you for your attention. I certainly welcome my co-chairs. If you have any final thoughts or want to add any things, to go ahead and pop on. Okay, if not, thank you again so much to everyone who took the time to share your expertise and thoughts and present today. And we look forward to seeing many of you back online this Friday, starting at 11 o'clock Eastern Time.